So hello everybody and welcome to Mask Together America's Back to School Health Forum. I'm Dr. Maria Gillespie. I'm a Mask ambassador for Mask Together America. We have lots of these type of people. And I also founded a local chapter called Mask Together Colorado, and that's been exciting. I'm a professor of mathematics at Colorado State University, and I'm very invested in this mission because I have a child with a health condition that requires extra protection. But everybody's here for all kinds of reasons. So I'm really glad everybody came and we're all here together today. Speaking of kids, I do have 2 kids and it's Sunday and I will be in and out. I'm the tech host and the sort of person who's hosting the Zoom meeting for this meeting, but there are lots of leaders here. And so I might have my video off from time to time, but I'll check in to do the recording and things like that. So I do want to point out all the people here with the Mask With Us backgrounds, the Mask Together America backgrounds. These are all people on the team who helped make this event a reality. So thank you to everybody. You can wave or say hi. There's Julie and Evan and Karina. And yeah, it was really a team effort to put this together. And this forum that we're having is so important because we're facing so many health threats in America all at once. And it's so important that we band together and learn better ways to protect ourselves and our communities. So we have 3 amazing speakers lined up today. So Dr. Mike Hoerger is already here. He's going to be our first speaker. Then we have Dr. Judy Stone next and Dr. Robi Tamargo, who also just logged in. Hello. And so we're very excited for all these speakers today. We're going to learn so much from all of them. Mask Together America is all about health education, and we hope you learned something today. I'm certainly looking forward to learning something today. And so now I'm going to turn it over to Karina, who's going to be the MC and asking all the questions of the speakers and everything.
So hello, everyone. Welcome to Mask Together America's Back to School Health Forum. As Maria said, my name is Karina, and I am a coordinator for Mask Together America. Outside of that, my day job is being a PhD student in language and information technologies at Carnegie Mellon University here in Pittsburgh. I'm excited to be the MC today. So for those of you new to our community, a bit of background about Mask Together America. We are a volunteer organization created in 2020 to raise awareness by featuring people who wear masks, sharing annotations of published materials. Mask Together America is a volunteer organization who are focusing on publishing materials on preventable respiratory infection, hosting expert forums like the one you've joined today, and just generally raising awareness to promote public health. We're also supported by a huge community of people like all of you on this call who are devoted to educating people about the layered approach in respiratory sickness prevention. We're also kind of functioning as a long COVID support group, especially focused on a layered approach to preventing reinfection and further long COVID. We've also done a lot of advocacy initiatives, including creating a health justice toolkit and a toolkit to help stop the mask bans cropping up across the US and the world, which we'll talk about at the end of the forum. So in the spirit of public health education and raising awareness, we're joined today by 3 health experts here to talk about the state of COVID and other transmissible illnesses today, and just the tools available to us to prevent infection. So I wanted to thank all of our community members for joining this forum. And also I want to thank Julie and the rest of the Mask Together America team, including our host, Maria, as well as Sydney Hollingsworth, as well as Evan, who's on this call, who contributed a lot to putting this forum together and enabling us to have a conversation on protecting our health from a lot of these dangerous diseases. So first up, we are very grateful to have Dr. Michael Hoerger as our esteemed guest speaker. For this first segment with Dr. Hoerger, the topic of our discussion will be COVID defense strategies that don't abandon the high risk. Dr. Michael Hoerger is an associate professor of psychology, psychiatry, and oncology at Tulane University and an international expert in psychosocial oncology and COVID prevention. He's the founding program lead for the Tulane Cancer Center's Population Science program and co-lead for the Louisiana Cancer Research Center's Population Science program, helping coordinate 80 faculty-level cancer scientists across Louisiana. As a licensed clinical psychologist with a PhD, with training in medical science with an MSCR credential, and financial analytics and management with an MBA degree, Dr. Hoerger is a transdisciplinary scientist dedicated to organizing researchers, clinicians, patients, caregivers, trainees, and community partners to improve health and quality of life. He's the founding director of Tulane's Health Psychology Doctoral Program and the Psycho-Oncology Research Program. Best known for research in palliative cancer care, he conducts psychosocial studies that empower patients and families across the cancer care continuum. Since the onset of the COVID pandemic, he has served as the founding director of the Pandemic Mitigation Collaborative and is recognized internationally for leading a widely used COVID dashboard. People with cancer remain the largest group at known high risk for severe COVID-19 outcomes, and COVID is anticipated to drive excess deaths, disability, and early retirements worldwide through 2033 and beyond. So that really underscores the importance of Dr. Hoerger's research. And you can check out his data dashboard, I believe, at pmcdata.com, or if you Google that, that should be there. So without further ado, we'll now move into the discussion itself. A little bit of logistics. So the organizers have a list of prepared questions that we'll ask Dr. Hoerger first. And after that, with any remaining time left before our scheduled end time of 4 o'clock Eastern time, we'll take questions from the audience. For audience members, if you'd like to ask a question, please write it in the Zoom chat at any time, and then we'll go through and ask them in order until time is up after we've gotten through our prepared questions. So our first question for Dr. Hoerger, how can we protect kids from long COVID?
Thanks for hosting and for having me today. Sorry for the technical issues. I think that's a really important question. So probably a lot of people listening have heard that the most common chronic illness in children now is COVID. And so it's very important to take that seriously, especially because our data are always lagged. So when you hear an important finding like that, it's based on data that are often a year and a half, 2 years outdated. And then people have accumulated more COVID reinfections by the time the study is completed and analyzed and it goes through peer review and gets published. There's always a big delay. So as with the MaskTogetherAmerica graphic on the Swiss cheese model, you want to use multi-layered mitigation to reduce the risk in kids. And that's very challenging because you have in the US right now more barriers to vaccination that are being thrown up. And that's a problem that's existed around the world in most countries for quite a while. So this is something that's becoming more uniquely American, although in the US people may think that the anti-vax sentiment is more common here. There's just been more barriers to access to childhood vaccination around the world. So that's concerning. On top of that, you have a lot of apathy among parents in terms of getting children vaccinated. And so if you look at the annual vaccination numbers, they're often very low in the 5 to 10% range for children among kids who are eligible. So that's, often the first line of defense. The public health agencies always say the best approach. I think it's the easiest approach. So you can't just rely on one layer of mitigation, but it's one and done, until the next vaccine. And so that's a pretty simple approach for people who can get it. In addition to that, masking for kids who are masking, the best approach to that is to have a well-fitting, high-quality mask. And so people should hopefully know what that is at this point. But a high filtration mask, if a child's old enough, they can wear an N95, but N95s were designed for occupational exposure, and young children aren't supposed to have jobs, so N95s are not children-sized. So typically that would be a KN95 or KF94 or something similar to that. There's also elastomeric masks for children. So Julie's putting on a flow mask right now, an adult-sized flow mask. But there's a couple adult-sized flow masks, and there's flow masks for kids as well. And so that's what my kids wear, and that's a really great choice as long as it fits someone okay, because it gets a really good seal. And so if you have high filtration, you have a good seal, that's going to be very protective. And then in addition to that, in terms of multi-layered mitigation, you'd want to have ear cleaning, air monitoring, frequent testing, especially if somebody is showing symptoms or has had a known exposure, that sort of thing.
Thank you so much for that answer. And yeah, totally agree. A layered approach of vaccines, well-fitting masks, and isolation and testing is really important, especially for the kids. So I guess leading into the next question, so beyond basically all of those approaches you discussed, just beyond wearing masks as adults and making sure kids are masked or in safe spaces under our supervision, how do we mitigate the risks of long COVID when we can't supervise our kids, like when they're at school or in extracurricular activities where we're not chaperoning all the time?
Yeah, I think that's a really huge challenge for a lot of parents. I mean, if your child is masking at school and they're the only kid masking there, and adults are not masking, then to me that's an environment where I wouldn't trust the situation personally. But other people, maybe they've made those social connections and feel like they can trust their child in that circumstance. I think it's very difficult because kids have such a hard time masking correctly, or at least many kids do. And so if you have a situation where the adults are not masking and don't understand masking, then it sets up a situation that's designed to fail a lot of the time. So I think that's pretty difficult, and that's really all you can say about it is people need to make that decision of whether they're going to put their kids in that sort of environment, knowing what the long-term consequences may be.
Yeah, for sure. It's a tough choice. Next, are pediatricians offering COVID and flu shots as routine vaccinations during annual checkups?
Well, that's hard to say how things are going to look because last year, the updated vaccine came out, I think maybe about late August, maybe it was the first week of September. And so that's when pediatricians, did all the work to get the vaccines and started rolling them out and all that. This year, I think it's very unclear what's happening with vaccines. And to the extent things are unclear, that's going to create a lot of issues. And so historically, I think logistically, it's been challenging for pediatricians to offer vaccines for COVID because the doses differ based on age and brand and all this. And you may have to buy a minimum of 10 at a time or something. And so there's just kind of some supply chain issues that go into it. But if you make the process even more difficult, then fewer pediatricians are going to offer them. And so to me, that's a struggle that we may see, regardless of what the policy is, with the general sentiment from the federal government being less supportive of vaccinations. You're going to see more obstacles. And what that means is that in rural areas, even where people are eligible for vaccines, you're going to have less of them being offered. In states that tend to be more politically conservative, you're probably going to have less offerings just because it's adding on to existing sorts of barriers. And so I don't know to what extent child COVID vaccines will be available where I live, for example. And I think there's a lot of uncertainty about that.
For sure, yeah, especially given current policies, there's a lot of uncertainty about the upcoming season, which is why other protections are also really important. So yeah, thank you so much for answering that. Next question. So we know that you are a parent to a few kids. How do you feel about other parents choosing to opt out of vaccination for their kids?
I think it's unfortunate for their children. I mean, it doesn't affect my children much at all because the vaccines reduce transmission somewhat, but it tends to be relatively fleeting, that effect. And again, the data we have on that are always lagged. And so you don't know, how well the recent vaccines are doing relative to what we saw 2 years ago or 3 years ago. But my gist level representation is that when somebody gets a vaccine, their risk of getting COVID is reduced for maybe about 4 to 6 months. And it's not a light switch. It's not like 6 months go by and then, oh, now you can get COVID. It's variable across individuals. Some people may have much more enduring immunity from vaccines, some people less. So there's lots of uncertainty. So don't overstate it or understate it. But that means it's something that can't really be relied on in terms of somebody else's kid getting a vaccine protecting my kid. There is some probabilistic effect of that. But it's small, and especially when you have only annual vaccines, if we even are able to maintain that, eligibility barriers, and then a lot of parents not vaccinating their kids anyway. So it's unfortunate for the kids. It's not something that affects my day-to-day decision making really at all.
Yep, it's true. It's like I'm going to get vaccinated no matter what. And if I have kids, I'm also going to get them vaccinated no matter what, and also protect them in other ways. So yeah, I definitely feel that. Moving on, is there a relationship between long COVID and the rise in prevalence of chronic illnesses in the US, and how does that relationship work?
Yeah, so I think that's pretty certain that repeat COVID infections are leading to long COVID. The way that people view long COVID is like it's this specific condition, but it's actually very heterogeneous. And a lot of people who are experiencing effects from COVID infections and reinfections don't identify with long COVID. They either don't make the connection that their new health struggles are related to their infections, or the terminology of long COVID just doesn't seem as relevant because it's not like they're always experiencing long-term symptoms that they experience at the onset of their COVID infection. It could be various new sorts of health conditions. And for people that are skeptical of that, there's a few things I would look at. So one is the Swiss Re report. Swiss Re, SWISSRE. Re is for reinsurer, and they're the second largest reinsurer in the world. They insure smaller insurance companies, and so against catastrophic losses. And so if you're a big, powerful reinsurer, you need to make money by knowing the risk of things. And in 2022, they basically were of the understanding COVID is over. And then that didn't work out very well for them financially, because then they're selling policies to insurers where they're not charging enough because people are still getting ill, they're still dying. And so, you lose enough money and you say, we have to study this in more detail. And basically they find out that the way that most people had been calculating excess deaths from COVID was a vast underestimate. And lots of people were still dying as a result of COVID, and are still dying this year and are still going to be dying. Their projections go through 2033. And so I mentioned that because if people are still dying of COVID, that means that people are also developing chronic health conditions from COVID. You're not just going to have people die and not get chronic conditions at all. And in fact, that's what you're seeing more of. It's less of these acute COVID deaths, and it's more 3 months, 6 months later, people have a heart attack or develop or aggravate a health condition. So that's part of the story. Easy ways to look for that. You can also look at the retirement numbers, and you'll just see a lot more people are retiring early. And if you just look at very simple statistics, it looks like about 2 million additional Americans are retired beyond what you might expect. And if you do more formal, serious sort of calculations, it's probably 2.5 to 3 million. And then if you look at the disabled worker population in the US, that is still way up. And that's probably about 2 million people who are disabled and working, that's in excess of what we would expect pre-pandemic. So those are kind of some of the obvious patterns. That's real, hard data that you could just look at and makes pretty good sense to people. I think sometimes people overstate some of this. So all of that is very serious and very bad. But there's like discussions about turbo cancer, and people think of that as like something from a vaccine or something from you get COVID and now you're much more likely to get cancer. And there's probably a risk of people being more likely to develop cancer, but that's not really known yet. And so you'll see these reports of like the increase in the incidence of colorectal cancer. And that's something that's been going on for a while, but sometimes people think that that's all because of COVID when it was something that's been going on. So yeah, you have a lot of evidence for that. You have some misinformation that sometimes gets caught in the mix, but it's very serious. And in the Swiss Re report, they do try to break down the categories where they're seeing more excess deaths. And you see a lot more cardiovascular deaths. That's about a third. You see more cancer deaths. So you are seeing more people die of cancer. We don't know yet to what extent COVID is increasing cancer, though. because people who have cancer are very vulnerable to COVID infections. And so it could be that it's increasing the mortality rate among people who have cancer. So there's a lot of uncertainty. And even that is only getting at about half of the effects. So in terms of what COVID is doing to people's health, in terms of other conditions, it's a real hodgepodge. And half of what it's causing are kind of miscellaneous things that are small enough percentages that it's hard to quantify. And that's why a lot of clinicians, I think, don't fully get all of this, because if COVID was just causing acute illness, if it was just causing one particular health condition, that might be something that clinically you might see. But when it's so many different things and you're a clinician specializing in one area, you're not necessarily going to notice a 2% increase in the size of your patient population, or 5%, whatever it might be. So yeah, very serious, lots of good evidence for that.
Yeah, for sure. Thank you so much for answering that. And I guess the next question was going to be, how does COVID affect the rise in cancers? But I think you already kind of covered that. So I think we can go on to the next one, which is, will putting high tariffs on pharmaceuticals affect the prevention of infectious diseases? And what would that effect look like?
Yeah, I thought that was a really thoughtful question. And so, I think probably the biggest thing is just we're in a very difficult stage in our economy. And I've been saying for about 6 months, I think we're in or headed into a stagflation situation where there's a lot of things going on that shouldn't be, and that will be economic textbook examples of what not to do. And they'll be useful long term, because stagflation is a really serious issue that's hard to navigate. And by showing how we deal with it so badly, it will suggest clues in the future for how to tackle this problem. And so what I'm suggesting is things are getting more expensive, but people are also losing employment opportunities. And this is a very difficult situation to deal with historically. And we're basically dealing with it the opposite of how we might. So examples would be, with all the federal budget cuts, you're reducing the federal employment numbers. Tariffs, you're driving up prices. So it's just kind of hitting people in both ways. And so if you were going to try to deal with this, you might actually do the opposite. Like you might look at how do you improve international trade, with caveats around that, because a lot of our trade policies tend to have fewer worker protections when we try to improve international trade. How do you deal with unemployment? Well, instead of laying off a bunch of people, you could hire more people. An example would be, right now there's a lot of issues with federal research funding, and that's creating huge uncertainty in research, medical settings, academia, and that leads to a ton of layoffs. And if you look at like the 2008 recession, one of the things that worked really well was putting more money into research. More people get hired, more people are spending money, stimulates the economy, all that sort of thing. So you have a very difficult situation. And if you're seeing this difficulty of higher prices, more uncertainty around employment, people are going to struggle to spend on mitigation things, as an example, among other things. And so, imagine if you're struggling to make ends meet, are you going to go out and buy a large box of N95s? I mean, probably not. Are you going to go out and buy some HEPA filters? Probably not. And so, it's important to keep this reality in context, because when we're talking to people about multi-layered mitigation, if somebody can't afford it, that's not very helpful to them. So that's my big picture perspective on it.
Thank you so much. And yes, as Evan said, this is why Mask Blocks and other free resources that give out free air cleaners and masks are so important, because some people just can't afford them. So speaking of finances, how do the recent NIH grant cuts affect our future in general? And also, if it applies to your research, how might that be affected?
Yeah, sure. I mean, it's creating a ton of uncertainty right now. It's leading to layoffs. It is, I think, having the most devastating effect in terms of scientists on very early career people. because it always trickles down to the least powerful people. So a big issue I see is people who are applying for PhD programs are less likely to get admitted because there's less funding available. There's more uncertainty. When things are uncertain, people don't want to hire, and they don't. And being a PhD student typically means you're hired. It's a full-time job. You're doing research. You're doing all this stuff. Most PhD programs, not all, but most are paid for. And so you get rid of that funding, and that you're basically creating a bunch of barriers to people entering the field of science. So that's part of it. Part of it is just studies being cut, where you might have a study that's already 3 or 4 years along, a 5-year project, and the study just gets pulled, or it gets pulled temporarily, but while there's litigation in progress, and lots of people get laid off, and you can't track your participants longitudinally, and the study either collapses or close to it. So a lot of it is just very wasteful cuts in terms of destroying value that was created by ending projects. But it's going to cause long-term scientific harms too, because in addition to pushing all these people out of science, losing all this research, there's the forward-looking problem of certain topics are just not going to get funded. And so as an example, I have a COVID-related research grant that's under review by a non-NIH funder that I was planning to take and submit a similar version of that to NIH this past June. I could not do that because there would be no point. It would be a huge waste of time. It's so extremely time-consuming submitting a research grant that people may not understand that. And so why would I waste 100 hours of my life to submit something that has essentially a 0% chance of funding? And even if it was a non-controversial topic right now, often that may mean a 4% chance of funding. So going from 4% is not great, but going from 4% down to 0% is just pretty difficult. So that's a circumstance a lot of people are in. So it's a pretty bleak moment for science. I hope that it leads to some reflection in the future and improving things.
Yeah, for sure. I feel you on the fewer PhD students being admitted and just less funding. Yeah, everything's really uncertain. So speaking of work, jobs, how do people at high risk for infection and serious outcomes work in person safely?
So same process as described before. So multi-layered mitigation, and there should really be a focus on high quality, well-fitting masks. And so people can look up how to do a DIY fit test. That's something that can be very important. You can look up how to do a seal check. Anything to get your mask to fit better is going to be optimal in that sort of circumstance. Something else that would be useful, if people can afford it or if they have a local mask block that has it, is to assess the air quality. And so if your air quality at work is really good, you're going to be in a much safer situation than if the air quality is very bad. And I wouldn't avoid masking regardless, but I think that's something people would want to know. If you're working in a very poor air quality setting, then you want to take additional steps to improve the air cleaning.
For sure. Yeah. Clean air. Yeah. A lot of classrooms, a lot of workplaces have really high CO2, which is really bad. So clean air is definitely important. Thank you so much for answering that. Again, still kind of on the topic of work and your work. So you are a professor within the school setting. How can students with long COVID seek accommodations from teachers or their school administration? And what accommodations might they want to seek that would help them?
I think that's pretty difficult. I think most people would be denied accommodations because, one, there's so many defense mechanisms and so much denial of the reality of what's going on. It's not talked about. There's just kind of this oppressive climate in many school settings, K through 12 and universities, of just, this is what you're supposed to do. And that's a long-standing issue. And encouraging people to push through illness and show up anyway and all this sort of stuff. So that's pretty discouraging. People may be able to negotiate accommodations. But I mean, it's very tough. A lot of professors just have this mentality of just show up, butts in chairs, that sort of thing. If somebody is a teaching assistant or a graduate instructor, whatever the title might be, they may be able to negotiate something with better safety as a worker than as a student. As a student, you have fewer and less enforceable sort of rights, but as a worker, you may be able to get accommodations. And so I've known of people getting like HEPA filters added to their classrooms and things like that. And sometimes that's been negotiated into collective bargaining agreements. Sometimes it's more informal. But yeah, it's a pretty difficult circumstance at most universities, most schools.
For sure. Yeah, I did something informal when I was a TA. One time I was doing in-person office hours and somebody like wouldn't stop coughing. And I was like, hey, professor, I'm going to be doing my office hours remotely from now on. And he was like, okay. So
yeah, I mean, something important to keep in mind is that schools and large organizations can be thought of as real estate holding companies. And so they have a vested interest in non-remote options, because if a university said we're going fully remote, what would happen to the value of their properties?
True.
They would lose so much money. And that's true of most large organizations. If they were forced to take COVID seriously, they would lose so much money in real estate that they would collapse. So that's important for people to keep in mind. And that's true of many, progressive sorts of organizations, is that a lot of their money is tied up in real estate. And if your money is in real estate, you have a vested interest in things not being remote and pushing people to be in person and safe in the short term.
That is unfortunately true as well. So yeah, speaking of workers maybe having more power for mitigations, what accommodations can employers give to their high-risk employees?
It really depends on the perspective. Like, my perspective is safety as much as possible, but a lot of people are not going, and a lot of employers or bosses or whoever are not going to have that perspective. So I think it goes back to what we're saying about, similar to students, of well-fitting, high-quality mask. Try to negotiate what you can, often with power differentials, often on an individual, informal basis, often where policies may be harmful or illegal. But it's very difficult. And I think it's important for people to reflect periodically on what they're tolerating and whether that's a long-term strategy that they want to pursue. And so people may switch careers. A lot of people have already. People may switch to entirely remote work.
Yeah, that is true. Remote work does still exist. I myself just finished a fully remote internship that aligns with all of my PhD research. So you deserve that. Don't give up and say, oh, I don't know, remote work doesn't exist. It does. So yeah, that is definitely an option, even if it's scarcely available. So yeah, speaking of remote work and maybe working from home, a lot of people live at home with their family members or go visit their family members. If somebody has an immunocompromised family member, I know your general layered precaution answer might already cover this, but is there anything else additionally that people should do to protect their immunocompromised family members?
Yeah, so the general advice applies, but I would have a greater focus on testing. And so there's a lot of misinformation about testing. And so a lot of people like to poo-poo on rapid testing of, I had this case of COVID and the rapid test didn't catch it. And you ask them and it's, well, they tested once and they use some C-tier brand and, all this stuff. And they may or may not understand that a rapid test is designed to catch high levels of infectiousness. And so you could have COVID and it doesn't catch it because you never had a high level of infectiousness, or you didn't happen to test on that day or whatever it may be. But having a tool that's very good at catching high levels of infectiousness is really good for stopping forward transmission. So it may not catch all of those low infectious cases, but it can be really helpful in protecting somebody who is vulnerable, immunocompromised, doesn't want COVID, takes all of this very seriously. So that's something I would consider. And a lot of people may not know what brands to use, so I encourage people to look into that. There's lots of information on that. The brand of rapid test that I use most frequently is FlowFlex, and I don't get any money from them. You do your own research into the statistical properties of the test. But that's a pretty good test, and it's cheaper than some of the rapid tests that are actually worse quality. So look into that, but lots of good options. The other thing I would think about is if somebody is immunocompromised, often, not always, their response to vaccination is lower, and there's overlap. So somebody may have a health condition where they can't get a vaccine, or they've had a bad response to it or something like that. So there's lots of gray area in it. But in general, if somebody's immunocompromised, they should look into monoclonal antibodies. And so there's one called PEMGARDA that is still available, and it's very difficult to access. But I recommend people looking into that. It's an infusion, and that's partly why it's difficult to access. It's partly difficult to access because there was previously a precursor of this, Evusheld, that stopped working after there was enough viral evolution. And so clinicians kind of got annoyed with this approach and don't really want to pursue it again. But PEMGARD has held up pretty well for a while now. And so people can look into that. And I have known of some people that have been able to get it. It's just very, very tough.
Sure. Yeah. Thank you so much. Thank you for underscoring the importance of serially rapid testing, even if you don't catch all of the positives. Kind of reminds me of like the smear microscopy approach for tuberculosis. It doesn't catch everything, but it does catch the really infectious, really ill patients, and that still saved a lot of lives. So yeah, testing is very important, especially on a big scale, to prevent more transmission. So returning to the topic of accommodations, a lot of patients from our community have experienced their healthcare providers refusing to mask. Sometimes they'll give the excuse that the patient isn't immunocompromised or not immunocompromised enough. I think somebody said, "Oh, you're not neutropenic, even if you're immunocompromised." And so yeah, is there kind of an industry standard definition of immunocompromised as sort of a threshold above which providers should mask?
No, in my understanding of the evidence. So I think one thing that I hope we see in the long run is masking in medical settings as a general rule, much as there is hand hygiene. This is not poorly understood. This is poorly understood, not just based on evidence, but because there's so many defense mechanisms that apply to people in medical settings as well. But there's lots of dogma. There's lots of things people were trained in that don't really apply and requires them to change their worldviews and all this. But if you understand the evidence of infectious disease, you have to know that in the long run, masking needs to be very important in medical settings. So that's where we're at. I think it's quite possible that whoever moves the needle on that the most will win the Nobel Prize 25 years from now. That's the significance of that issue of understanding airborne transmission and mitigation. There's a reason why I say that, and that's one, because it's true, but that's how big the obstacles are to making that happen. So that's where we're headed, I hope. And it looks like in Canada, there's some regulations that are in the works that are potentially moving forward with that path. There's tons of opposition for psychological and short-term financial and dogmatic sort of reasons. So we'll see what happens with that. But if some country makes a big step along those lines, that'd be very helpful. We did a study on the 2023-24 winter COVID wave in the US, which was a very large wave, second largest wave as far as we know of the pandemic. And we looked at top cancer centers in the US. And among the top cancer centers, they were all over the place in terms of their masking policies. But if you looked at the very top, the most elite, the best cancer centers, masking policies, universal masking policies were very common. It was about 80% of the places. And the NIH Clinical Center required masking from November 1st of last year, I think, until somebody here probably knows the date, I think early April, something like that. We'll see what happens, this November. And that will be something that's debated between their hospital epidemiologist and more politically oriented people. So yes, we know what people should be doing. How do people navigate that is much more difficult. You'll sometimes see these remarks of like, oh, just go get care somewhere else. Well, it's not that easy because especially if you're in a smaller town, you may have very limited options. The waiting lists are very long. You may have somebody who is the best clinician for your particular need, despite their COVID behavior. So those are very difficult realities for people to navigate. And again, well-fitting, high-quality masks are something that reduces that risk a lot. It doesn't reduce it completely, and it doesn't reduce it if you have to take your mask off for your medical care because of whatever the treatment or diagnostics are.
Yeah, for sure. It's kind of sad that we know what we should be doing, just need to move forward and do it. Next, it might seem really obvious, but we did still want to ask it because, I personally have come across some people with long COVID who just like their symptoms improved and they thought, oh, they were in the clear, they didn't need to mask anymore. But I don't think that's true. So just wanted to clarify, are people with long COVID susceptible to reinfection and getting worse long COVID from that reinfection? And if so, how can they prevent such reinfections?
Yes. So if somebody has had COVID, if somebody has had long COVID, they are still vulnerable to future COVID infections and they may be more at risk. If something harms you, and then you're thinking it won't harm you again in the future, that doesn't usually pan out very well. And there's evidence for that. If you look at the El studies, for example, you see that one of the clearest predictors of having negative long-term effects from COVID is what happened initially. Were the symptoms more severe? Were they hospitalized, right? And it's not a perfect one-to-one. There's so many people with mild acute infections that doesn't mean you're safe if the initial infection is mild symptomatically. There's going to be many of those people that develop long COVID and other health conditions not recognized as COVID related. But if somebody develops long COVID, then to me, they're probably on that trajectory of that being predictive of worse outcomes. So yeah, to me, that would be a situation where you would take things more seriously and you would do kind of a behavioral autopsy of like what led to the failure. Was it a lack of testing? Was it having a mask that didn't fit very well? Was it you were in this setting and the air quality was really bad? What could you do differently to avoid that in the future to the extent possible? And people are very oppressed, so there may not be everything that they can do, but there could be some things they could do to improve their chances in the future.
Sure. Yeah. Thank you so much for clearing that up. Next, looking at some of your data related work, what is the importance of looking at COVID data and forecasting the future of infections?
Well, I think that's something that is very helpful for people who are grounded more in reality, not enough to take all of this very seriously all the time, but people who will actually adjust their risk behavior as transmission increases, which is a lot of people. A lot of people are in that kind of spectrum. So for me, it doesn't actually matter very much, despite doing all this data work. Transmission can be low or very low. That's actually still very high in the absolute sense. So a relative low doesn't mean you're necessarily safe. So it doesn't affect my behavior really at all. And I'm so confident in the fit of my mask that I can go to a meeting where I assume there's 3 people with COVID and it's not going to be an issue for me, presumably, knock on wood. But you have a lot of people who, are behind on their vaccines, right? They were going to get it last November. but things got busy or they got COVID and they were like, well, I'm supposed to wait some amount of time. What's the guidance on that? I don't know. And time goes by and then maybe it's been a year or 2 years or something. And so, oh, they hear about a wave coming or they're in the Bay Area and they're like, everyone I know has COVID. That sort of information can be really helpful for people who are willing to adjust their behavior. It can help lead people to test more, and that can reduce forward transmission, and that may save a life if somebody was about to see their grandfather or something, and they thought they had a cold, but then they had enough sense to test because they heard transmission was high and stop that forward infection.
For sure. Very important for people who might be willing to change their behaviors with surges. Next question. Would you be able to share your advice for advocates who feel lost and frustrated by the drastic changes in public health policies and maybe some motivation for still continuing to do the work?
Yeah, sometimes people get really down about how things are and how they're going. But I just say look at the scope of the challenge, that where are we going to be in 30 years? It should be a much better situation, and the science has to move that way because that's what's correct. And so if you can have that long view in mind, I think that's something that can be really helpful for people, and just understanding how hard it is to make change, how slow it is, and understanding that, then it's easier to be a part of it. If you think this is something that you can solve in the next 3 months or the next year, that's very discouraging. But sometimes people get discouraged when I talk about the long view too, because maybe somebody has really bad long COVID or other health conditions. They're like, Mike, I don't know if I'm going to be here in 5 years or 10 years or that sort of thing. So, but that's how I look at it, is long view. What can we do to get to that point where we're behaving in a way that makes a lot better sense from a scientific and public health perspective? And, that's not just about those of us here, that's about kids as well. So setting up kids to understand this stuff and carry on and all that.
Yeah, for sure. I always want to pass my knowledge on to the next generation and set them up for a future where they can survive. Yeah. Going back to data, CDC has recently made some changes to how they're reporting data on infectious diseases. So could you talk about how reliable that data is? Yeah, and also just their general wastewater surveillance reporting and any other
Sure.
infectious disease data?
Yeah, I'm still digesting it. So it's like asking me, how is my meal when I'm in the middle of eating it? Okay, I can give you a sense, but I'll have a better sense in a couple of days. So there's a lot of problems. There's problems with the process. There's problems with some elements of the data. There's some elements of the data that are okay, as far as I can tell, in the middle of my data meal. The process problems are the CDC just made a bunch of big changes in terms of how they're providing COVID data. And I'll describe the change, and it'll make sense to some people and some people won't. The data are from wastewater, okay? You're getting sewage, poop, and you're seeing how much virus is in it, okay? There are people who have PhDs in that area of science, okay? And there's a whole chain of people with PhDs in different areas of science going from sewage to CDC numbers, okay? So you somewhat have to trust the process of, there's people out there with specialized expertise that I would not want, you would not want that, or we would have that expertise, right? I have no interest in studying sewage at that level, right? So one of the issues is there's all sorts of things that can make that data messy, okay? If it rains a lot, that can mess up the estimate of how much virus is in the water, right? And it's really tricky. You can look into this, go on ChatGPT or Google it or something. But it's like, if it rains a lot, you would think that would just dilute the virus, but it does weird things where sometimes the rain loosens up sewage in pipes and it can increase it and then decrease it. And so it's just very challenging. So what they had been trying to do was deal with some of that noise, and they call that normalizing the data. So you could do things like measure what is the rainfall, how much sewage is moving through pipes at what rates and this sort of stuff. And that's how they had been doing it, had been doing it a long time. And then they just put out this notice on Friday. Yeah, we're not doing it like that anymore. We're just going to use the raw data. We're not going to correct for any of that sort of stuff. And that's just a really strange approach, because you would think if you could account for some of these extraneous variables, these confounders that are adding noise to things, you'd think you'd get a better signal. That's just a pretty rational sort of thing. Make the data better accounting for these frustrating variables. And they said, yeah, we're just not doing that. They gave some kind of BS explanation. It was on Instagram. Some epidemiologist was like, you can tell no scientist wrote this because it doesn't make any sense at all. And I'm thinking that they had ChatGPT or Grok or something, right? Some justification. I emailed the CDC a few months ago saying, why do you use these blue maps that every map, geospatial analysis book says you shouldn't be doing? And they responded back with something that was written in AI, as far as I could tell. So, you're getting some, weird justifications. So they did that. They switched to data that look like it's not as good. They have weird stuff going on with how they're labeling very low, low, moderate, high, and very high transmission. They kind of changed some of the values and what value constitutes very low and what constitutes low in ways that look like it could be minimizing. It's not exactly clear yet. If you look at the CDC page right now, unless they changed it today, if you look at their graph of transmission levels, it says we're in moderate, but at the top of their page, it says low. And when they released the data, it said very low, and then it said low in a different spot, but it's actually moderate. So really messy, weird sort of stuff. As I dig into the data a bit more, I'm less concerned about the national numbers. So what I suspect might be happening is they were trying to deal with all this confounding, like rainwater stuff. And I think they were doing such a poor job at it that they basically said, we don't lose anything by getting rid of that process. And maybe that'll make things speedier, or there'll be less retroactive corrections. It could just be politics. I don't know, but I'm hoping that the changes aren't as bad as they seem, at least at the national level. At the local level or state level, people should just be a little more conscious that the estimates they're seeing, like if it says very high or very low, or if it's bouncing around a lot, maybe that's weather related, where the rainfall is affecting it or something like that, and the CDC is not accounting for it as well, but we'll see. And I think we kind of have to see that pan out over the next couple months. But I just encourage people to take things with a little bit more grain of salt, especially if their local numbers are looking a little bouncier. So that's sorry if that's too nerdy or over the heads of people who don't get as excited about data, but that's kind of where we're at. The messed up process part of it is, why would you do this in the middle or approaching the middle of a wave? You should do this during a lull when everyone can just digest this, that nobody's freaking out, no one's feeling like it's political, whether it is or not. It's not when we're, throwing up barriers to vaccines, and explain it with a justification. Why couldn't the team involved with this put together a little video or post something on social media about it, or have a conversation like this, where instead of listening to me try to interpret what they're doing, have somebody from the CDC come and explain all this? So yeah, very, very frustrating. And it makes people really skeptical.
Yeah, sure. So if the CDC's data isn't super reliable anymore, what is the best way to get the latest data on infectious diseases, COVID and flu, but also other diseases in general?
Well, I wouldn't say that the CDC data are super unreliable. I would say that people just need to monitor them more closely and compare their sources. And so that's something I always do. And so the data that I put out are actually mostly a combination of data from the CDC and data from BioBot, which is the former CDC contractor that still puts out some data. They don't put out as much detail geographically as they used to. But you can compare these metrics, and they track pretty closely. And even with these weird CDC updates, they continue to track closely. It's shocking to me because their process of getting rid of this normalization sounds like a disaster. But when I look at the data, it's not, at least at the national level, as bad as I would have guessed. I would have guessed it would have been absolutely terrible, and it's looking okay. The strange thing is it makes the last two winter waves look much bigger. And and that fits with what I would have hypothesized and did forecast. It fits with in my opinion, he can speak for himself, Joe Eastman's work at WHN, where he has a model that tends to estimate cases a little bit higher than mine. And with this updated CDC information, it's looking a bit more like what Dr. Eastman has said. It fits a bit more with what Swiss Re has said of not expecting a decline in transmission, that transmission should be pretty similar year over year. So again, I'm in the middle of digesting it. There's need for caution and comparing different things, but it may not be as bad as we think nationally. Locally, we'll need to see over the next few months. Good sources to use. You can go to the PMC website, pmc19.com/data, and I've got links. Just scroll down a ways and you can get all the links to all the good dashboards in whatever state you're in if you're in the US, and there's links to all the international dashboards as well. So you don't need to listen to anything I'm saying. You can go check primary sources. But the other good website, in addition to the CDC stuff, is Wastewater Scan. And so I would encourage people to go take a look at that as well. And all the links are on there.
Awesome. Thank you so much. Speaking of just on the topic of ways to look at data, this is actually a question from the audience. How should transmission levels be understood during the troughs between waves? So how much can you relax your precautions and why? And how exactly is COVID transmitting during the troughs that we see on the graphs?
I mean, if you're looking nationally, those troughs are still very, very bad. And so, and again, this is where we're dealing with some new CDC data, which it's very strange when they do these things because it affects my reality of historical understanding of transmission, right? And one of the effects of their data update is, in my view, it makes the peaks a little bit higher and it makes the lulls a little bit lower. Before they did this update, my estimate was that we never really got below 200,000 new daily infections in the past, basically 4 years, even at the lulls. It may get a little bit lower than that based on these updates. I'll have more data on that soon. But it's still bad, and if it is 200,000 or 100,000, why would anyone want to take that risk? So to me, that's nationally, you can't really, if you care about your health, you can't really view that as like a time to go party or something. Locally, you could get very, very low transmission in particular areas, and so some people drop their precautions then. But the biggest thing that I know of is, among people who take all of this very seriously, they track those lulls, so that's when they can get done their riskier things that they have to do. And it's less about people saying woohoo, I'm going mask free today. It's more like, oh, that's when I've tried to time going to the dentist and all that sort of stuff. So that's how I would view it. Like, if I had the choice between a dental appointment on, New Year's Eve versus, June 1st, I'd probably go with June 1st. But there's local variability in that as well, though.
For sure. Yeah. Thank you so much. All right. We did start a bit late, but even then, I think we're a few minutes over time. So I think that will be our last kind of live question for now. There are some questions still in the chat. Dr. Hoerger, if you have time to stick around and answer any questions in writing in reply to the chat, that would be great. But obviously no worries if not, since we are over time. So yeah, regardless, thank you so much, Dr. Hoerger, for taking the time time today to talk to our community about protecting high risk. So we will now have a break, I guess about 8 minutes until 4:15 p.m. Eastern, after which we will be back with Dr. Judy Stone to talk about infectious disease preventive tools. So please do join us for our next segment at 4:15 p.m. Eastern. And thank you again.
Thank you all so much. I appreciate you hosting. And Dr. Stone, I hope you'll correct any medical wisdom that you can build upon. I appreciate you all. Thanks everybody for coming and talking.
No, you're just much more restrained than I am.
Thank you.
Thank you so much, Dr. Hoerger.
Hello and welcome back, everyone. For those of you just joining, my name is Karina, and I'm coordinator for MaskTogetherAmerica and the MC of this Back to School Health Forum. So thank you all for joining us today. We are so grateful to have our second speaker of the day with us now, Dr. Judy Stone, who will be talking to us about the topic of infectious disease preventive tools. Dr. Judy Stone is an infectious diseases physician and is experienced in clinical research. She is a senior Forbes Pharma and Healthcare contributor, a former columnist for Scientific American, and the author of a nationally recognized textbook conducting clinical research. She especially likes writing about ethical and social justice issues. She's now retired from clinical practice, spending her time writing and educating the public in her free weekly infectious disease newsletter, which you can find at drjudystone.com. As the daughter of Hungarian Holocaust survivors, Dr. Stone also has a long-standing interest in oral history. And so this, as well as changes in global politics, prompted her to write her survivor family's memoir called Resilience. She's hoping to do more Holocaust education now, and through telling her family's remarkable story, she hopes to teach tolerance and contribute to making the world a better, more peaceful, and more just place. So with that, we'll now move into the discussion itself. The organizers, again, have a list of prepared questions that we'll ask Dr. Stone first. And after that, with any remaining time left before our scheduled end time of 5:15 p.m. Eastern for this segment, we'll take questions from the audience. For audience members, if you'd like to ask a question, please write it in the Zoom chat at any time, and then we'll go through and ask them in order until time is up after we've gotten through our prepared questions. Starting with our prepared questions. So up first, the CDC isn't exactly warning the general public on circulating COVID variants. Does that mean we're out of the woods with COVID, or how else should that be interpreted?
As I say, I am far less tactful than Dr. Hoerger was, so you should be forewarned about that. No, we're not out of the woods with COVID. As he mentioned, there are at least 200,000 cases a day. This week, he reported that 1 in 93 people is infected, and there are 512,000 daily infections, 3.5 million weekly infections, and 1,300 to 2,000 weekly deaths. So we're not out of the woods by the way I count it. And we still take precautions wherever we go and mask anywhere we're indoors. And sometimes if we're outdoors, depending on the weather conditions and how many people there are.
Yeah, sure. Right there with you. Thank you so much for clearing that up. Next, we wanted to know, how will the U.S.'s withdrawal from the World Health Organization affect Americans?
It's a disaster. So much of what's going on is a disaster. It's bad for our security. It's terrible for diplomacy and for our influence and stature in the world. World Health Organization has unmatched global reach and legitimacy, and our pulling out of that really sends a terrible message. One of the ways it hurts us is that we rely on other people as an early warning system for what's happening. Many of the infections we face in this country start overseas. And for example, Ebola and COVID started elsewhere, Africa and Asia. And if we don't know about these things, we're going to have it here with no warning. And I gave Julie, I think, some links that she can put, or she did put in the chat. Thank you, Julie, because I'm not looking at the chat now. I'm looking at you, Karina. The other thing that's happening with this, so look at the Johns Hopkins article on the consequences of U.S. withdrawal from the World Health Organization. But one of the other things is that by our withdrawal from World Health Organization and from USAID, we're killing millions of people, especially by removing vaccines and nutrition. I can't believe that we're burning food supplies and contraception. I'm just horrified by what's going on.
Yeah, I'm horrified by those things too. We need more investment into public health, not less.
Right.
Yeah.
And in global relations,
Yeah,
building relations.
for sure. So speaking of another form of investment into public health, is everyone in the US going to be able to get the updated COVID and flu vaccines this season? And how are other countries preparing for distributing these vaccines?
You went out of order. That's okay. No, many people are probably not going to be able to get vaccines by cost, by insurance, and by the regulations. For example, one of the things that's particularly galling is pregnant women under the new revised rules from RFK Jr. Pregnant women are excluded from getting the COVID vaccine. Now, this is irrational because pregnant women have a much higher risk of having a bad outcome from COVID and ending up hospitalized or dead. And they also have a higher risk of miscarriage from COVID. So why would you want to ignore the science and keep them from getting vaccines? Other people, they now are excluding vaccines. Pfizer's vaccine is not allowed to be given to kids. And I would have to look. The Moderna vaccine will be available for some children, but mostly immunocompromised children. And the current administration doesn't want vaccines for anyone less than 65 unless you're immunocompromised. Again, none of this makes sense to me. I would encourage vaccines for everyone. We know that kids get ill from COVID, can die from COVID, and can get long COVID. So why would you want to eliminate it? They describe it as shared decision making.
Yeah, why would you want to eliminate that? Yeah, so I guess, speaking of like kids not being able to get Pfizer, another way of protecting ourselves that a lot of us in the community are familiar with is wearing a mask. So would you be able to talk about the benefits of wearing a mask? We all probably know that it helps against COVID, but even other than COVID, what else can be avoided by wearing a mask?
I love masks. I have a variety of masks. I have the flow mask. I have a new clear mask that I got for when I speak. It was quite shocking for people. I went to talk to a high school, and this clear mask, it has big filters here. So I joked it made me look like Princess Leia. But, I wasn't going to go into a classroom of 30 kids with no ventilation, unprotected, and that was, again, one example for me to tell them you have to stand up for what's right, even though it makes you look odd or look like an outcast, outsider. It's important to model what's right, and wearing a mask in this kind of situation is important. So, your question about other things that you can get, my family all are rabid maskers, and none of us have had COVID or RSV or any upper respiratory infection since March of 2020, when we started masking religiously or zealously, depending on how you view it. So it will prevent flu, colds, measles, RSV, all of those things. So not just COVID.
Awesome. Yeah. See, Dr. Stone is an example of how, you can avoid all kinds of infections by wearing a mask. And yes, as Maria just mentioned in the chat, Maria is modeling the OmniMask clear mask with, I believe, 3M filters on the side to make it work.
Okay. Yes. I couldn't think of the name of it.
Yeah.
That's it. Thank you, OmniMask.
Yes. So speaking of masks and other diseases, do you need to wear a mask, I guess, as source control if you're infected with measles? And does having been vaccinated for MMR make a difference, I guess, in terms of what source control you need to do?
Maria, were you asking me about making my audio better now or with the mask?
No, I actually was just talking about the OmniMask, and I just put that in the chat, the link on how we both made our audio better, and people can find the information. Thank you. Yeah.
That's fine. I just wanted
We can hear you great.
Yeah, and you helped me a lot with the OmniMask. Thank you. Okay, about measles. Karina, you were asking about if you're infectious with measles and wearing masks. So measles spread is airborne or by secretions. One of the problems with measles is you're infectious for 4 days or so before you get a rash. So you can spread the joy without knowing that you're doing it, and for an equal amount of time after the rash starts. And one of the problems is parents who don't vaccinate their kids and their kid gets a new rash or becomes ill, and they take their kid to the pediatrician, and in the waiting room, in fact, a number of children who are too young to become vaccinated. And that's a real tragedy. But one of the things I learned in preparing for this is that actually, if you get a rash from the vaccine itself, that's not infectious. Did that answer your question, Karina, or did I miss something since I got distracted?
No, I think that answered it pretty well. Thank you. Speaking of masks again, I guess, this is kind of the subject of our discussion. What are your thoughts on masks being restricted in some parts of the US, either in the name of like protests or honestly, like whatever?
You can guess. I'm I'm horrified by it. There's no good reason to restrict masks. And I find it ironic that the government is saying it's to improve our safety and reduce violence when they have all these masked ICE people going around attacking people. And you don't know whether somebody now is abducting someone or they're ICE abducting them legitimately. I mean, look at what happened in Minnesota, that anyone can put on can buy police or ICE suit off of Amazon or wherever to play dress up. And so you don't know if someone is really a police officer or a government agent or is just a thug, like happened in Minnesota when the senator was killed, when she was murdered. I've written, and hopefully Julie will put it in the chat. I wrote a couple of articles about mask bans. North Carolina said it's illegal to mask in public unless you have a contagious disease, but had no exemption for preventing disease or preventing asthma or other medical problems. And it's shocking that any property owner or occupant of the property can tell you that you need to take off your mask, and law enforcement can tell you to take off the mask. And Eric Adams, for example, in New York, wanted everybody to take off their mask when they walked into any store. It's really, from my perspective, it's all part of the facial recognition movement and surveillance society from the government now. They want to make facial recognition widespread, and in fact, just said that they can do that towards immigrants use facial recognition in at least some cities. The other, and they're saying they need to be able to recognize people that you need to be unmasked is lying, because there are studies that show that face masks are actually less effective than sunglasses in masking your identity. So all you need to identify somebody is seeing their eyes, probably less than that. The other thing is we have these forest fires coming from Canada and California, and I think Utah now, all over. And so air pollution is up, and they tell people to protect themselves, but aren't telling people to wear masks. So mask bans in that kind of setting, as New York City, are counterproductive. And it prevents people who are at high risk from public spaces, from participating in society like they could normally otherwise, if you're not able to wear a mask to protect yourself. And I guess my last comment is I liked something that Julie, I'll botch it. It's Jews for Mask Rights. Is that the name of the group? Okay. That when I spoke to them, when I was writing the post, talk about Jewish tradition prioritizing the sanctity and protection of life above all else. Jews are not permitted to endanger our own or others' lives or behave in ways that likely to spread illness or cause death. So that's another reason why we want to mask.
Yeah, for sure. Thank you so much for talking about the importance of masks and the counterproductivity of mask bans. It's kind of silly because I mean I can open my iPhone still while wearing a mask. Like it recognizes me from my eyes. So even if people are like doing it for facial recognition, that's not
Right. So they're just lying.
Yeah, that's really sad. Yeah, so going from masks back to vaccines, are vaccines still available for people like regardless of age? And also is the availability different across states?
Well, you're going to find them harder to get in certain conservative areas. The COVID vaccine availability is the same in each state, but there's a huge difference in uptake. And I gave Julie a link to share with you about that. And that's largely based on different politics. If you're told repeatedly that vaccines are bad and dangerous, which they're not, those are all lies, then you're less likely to want to get your kid vaccinated or get it yourself. As I say, now if someone's less than 18 years old, they don't want you to get a vaccine, or they describe it as shared decision making. But I'm sure a lot of doctors aren't going to agree to give you a vaccine if the feds are saying that they shouldn't. They don't want the aggravation. And otherwise, for this coming year, it's only indicated for moderately or severely compromised people who are less than 65. And I would say I don't understand why Novavax isn't available. And I just got my Pfizer vaccine a couple of days ago and really miss Novavax, which I like. I personally feel is, I won't say better vaccine. They're both protective, but has the least side effects because of the platform it's built on.
Sure. So that covers kind of the question of whether they're available across age. Now how about across locations and states? Like if somebody, if maybe it's not available in a certain state, can somebody go to another state or go to Canada to get a vaccine?
You can go across states for COVID vaccine. You can go to Canada, but you probably can't afford it, many of the vaccines. And right, again, as I was reading, a lot of them are limiting the availability until they satisfy some of their own local population first. Where you're going to see more problems are not the COVID vaccines, but with things like the hepatitis vaccine and Gardasil, which are going to be the next targets of this administration. And probably many states will ban Gardasil in particular, because it's sexually transmitted disease.
Yeah, it's really concerning, the ripple effect that this has on all the vaccines. Speaking of consequences of just public health failures, could you go into a little more depth about what are the consequences of lowering infection control, like getting rid of mask mandates in healthcare or reducing requirements for vaccination and having exclusion periods?
Again, it's horrifying. It's horrifying, and I'd be interested in what Dr. Hoerger, what hospitals he talked to that have mask mandates, because I wrote about Mass General and UCSF refusing to mask for even immunocompromised patients, asking them to. That just infuriated me. But some of the consequences, well, you're going to see increase in nosocomial or hospital-acquired infections, not just for COVID, but for everything else, colds, flu, everything, if you're not masking. One of the things that, again, anecdotal, but my daughter lives with a couple of housemates, and one of the housemates was recently hospitalized and came home with COVID, which he then gave to the second roommate. And fortunately, she didn't get it, which is a miracle, knock on wood, because she masks, and she opened all the windows and masked, and we had every HEPA filter in the house running full blast. But, that's sort of forward transmission of infections because the hospital is not practicing infection control. People are going to die from that, from other immunocompromised people getting exposed to COVID and dying from it. One of the things the CDC did is the hospitals as of May of last year, hospitals are no longer required to report COVID hospital admissions, hospital capacity, or hospital occupancy data. Again, if you don't track anything, then there's a line in a cynical book, The House of God. If you don't take a temperature, you won't find a fever. So during surges, up to 10% of hospitalized patients with COVID may have acquired their infection in the hospital. So hospitals are dangerous places. You should stay out of them if you can. And I agree with the other comments in the chat earlier. We have had signs up asking staff to mask when they come in the room. Most staff, it varies. Okay, we just had an experience. Washington Hospital Center was wonderful. They were more than happy to mask. They said, "You tell us what you need," and I'm happy to go there for any other care because of that attitude. Mass General, they refused, and the complaints to the Attorney General were denied, and all the way up the food chain. They just didn't care. So if there's, again, data that masked healthcare workers, there's a 50 to 60% decrease in hospital onset respiratory viral infections, and fewer people die. You may still from getting infected. And Julie has the link to an article by Michael Hlampus, who's written a lot about that. The hospital acquired, anyway, it just it reduces deaths, reduces transmission. And the other thing that I saw when I interviewed people for that story is how many patients avoid medical care because of the hospital staff or their physicians being unmasked, and that is a shame.
It's really a shame that a lot of physicians are not masked. Well, speaking of physicians and masking, how can long COVID patients, or really anyone high risk, or anyone who wants accommodations, how can they request accommodations effectively from healthcare workers and minimize retaliation and hostility from them? So, for example, we have community members who report that on the day of their surgery, their doctors and nurses greeted them without wearing a mask. So what are kind of their rights in seeking mask accommodation? How can they use those rights?
You don't have any rights. You used to have rights under the Americans with Disabilities regulations, but you don't have rights now. I hate to be that blunt. What we've done is, and I have physicians who will not mask. I have one physician who, that practice had HEPA units in every room, and everybody was wearing a good mask, and they stopped doing it, and they unplugged all the HEPA units. They're still sitting there, but they're unplugged now, and the doctors don't mask. And this is a rheumatology practice, so they deal with immunocompromised patients. It just is mind-boggling. Okay, I still have to go there because there's no other choice. So I just put on an N95, and as Dr. Hoerger said, if you can, try to make your appointments for the season where infections are lower, would be one advice. One of the things, if you can, I would suggest you try calling ahead of time and letting the practice know and see if they will accommodate you, as opposed to just walking into your appointment and saying, "Hey, please put on a mask." And if you do go, say, "Here, I brought an extra mask for you. Would you mind making me feel safer by putting this on?" It's a crapshoot. You should pardon my language, Julie. But most people will not accommodate you now. And I don't know what to do about that. As I say, we just try to call ahead and see who will. And I will recommend the hospital center because of that. I consulted disability lawyers for the one post that I think Julie, I've asked her to put in about, but when even the Attorney General, the state representative, the senator, and governor won't do anything for an immunocompromised patient after Mass General told her, "Forget it, we won't mask for you." We're in the wrong. We need a different political perspective and different ethical perspective, because with this administration, it's only going to get worse.
Yeah.
Sorry, I'm not cheering you up.
No, that's fine. Like, thank you for a brutally honest answer. But yeah, as somebody mentioned in the chat, I tend to also have something in writing before the appointment. And I would say sometimes if it's not essential and they've refused for any reason, like, oh, we're a small family practice. Oh, you know, whatever. Our finance department did a lot of research. Like, I'll just cancel the appointment. But obviously it's not possible for essential things. So yeah, at least better to know ahead of time. So moving on to the next question, the much more lighthearted topic of the decline in public trust in public health authorities. What are your feelings on that? And how can we rebuild that trust?
It's really hard. It's really hard. And again, I gave Julie a suggested resource, but some of it is building relationships ahead of time. Okay, there are people when I was in practice, there are a lot of people who don't like me because of my mouth and I'm so outspoken. But they still wanted me to take care of them because they know how compulsive I was about taking care of my patients and protecting them and insisting that things be done right. So I think that similarly, I'm well respected in my community now, and I occasionally write letters to the editors or op-eds about things because I have that pre-existing relationship. And I think engaging with the community and trying to talk to other people, as you all do a lot, um, you you're outstanding in your efforts to communicate with other people. It's emphasizing that we're trying to protect everyone in the community, the good intentions of your group, and rebuilding trust that way, and trying to find out what their barriers are to wanting to do it. I would encourage you too. There's a group called Defend Public Health. I would defendpublichealth.org. I would encourage you to look at them. They have various things that you can do. I would encourage you to go to fivecalls.org, and constantly they make it really easy to call your representatives. You have to keep calling and sending letters and letting your representatives know that these issues are important to you. And maybe if they're beat over the head enough, they'll respond to that. I don't know, but that kind of political advocacy is something that we're trying where more rational things are not necessarily working.
Yeah, for sure. Yeah, I've also been doing a lot of kind of contacting my representatives and hoping something will change. Yeah, it's really difficult out there. Are we now safer from other pandemics, or are we worse off, and why or how?
I wish. I wish we were safer. You gave Dr. Hoerger all of the cheery easier questions. We're better off in that we have new tools like the mRNA vaccines that could be adapted more quickly as new pathogens come up, like the bird flu. On the other hand, you have to want to use those platforms. And this administration has killed the bird flu vaccine that was being developed for people because they don't like mRNA vaccines. And they also like pretending that there's no bird flu around. So that's a problem. Our biggest problem is that RFK and this administration are just going out of their way to fuel mistrust and spread misinformation. With RFK saying that COVID is the most dangerous vaccine, that's not true. Them saying that it hasn't saved lives. Everybody that he has appointed has that same party line of being generally very anti-vax. Not 100%. He did break down and tell kids and parents in Texas that they should look at a measles vaccine, though he doesn't like it. But mostly we have to constantly battle the misinformation. And And that's why we're worse off. The misinformation, the cuts to World Health and USAID, as we talked about, that were our global early warning system, and cuts in surveillance. I mean, they don't do bird flu surveillance. They never did it properly. And they're basically not doing it at all now. You're on.
Uh, Thank you for, again, the brutally honest answer. I'm sorry to our community that we don't have better news. So yeah, speaking of other pandemics, specifically honing in on bird flu, are we safe from bird flu now that there's no really news or monitoring about it? And if not, how can we prevent bird flu infections?
Well, no news means nobody's looking. They never did proper surveillance at the farms. And certainly with many of the farm workers being migrants or being Latino, you don't even have to be a migrant. You just have to look Hispanic and you're going to get arrested by ICE now. So if a Hispanic worker becomes ill, they're not going to seek medical care because they're going to get arrested and deported. So you're not going to detect any infection that may be mild or go under the radar if you have to rely on that self-reporting and there is no active surveillance. In terms of what you can do, there are a couple of things. Mask, right? Especially, and I would say stay the hell away from agricultural fairs where people are displaying their prize chickens and cows and pigs. That's a real mixing bowl for spreading infections and getting recombinant viruses. I mean, they're cute, but they're little cesspools. If you need to go because your kid wants to see all the cute animals, wear a mask and have them wash their hands thoroughly after touching anything there. Don't play with ill or dead birds. One of my friends has backyard chickens, and she has it set up now. We talked about her risk of bird flu because of this. She has it set up so there's a tarp over her chickens, so they can't migrating birds can't poop on them. And they also have it set up so that when the birds are fed, they change their clothes before going in the house after working with the chickens, or going through an area that's contaminated with the chicken droppings. So and there are some concrete, again, I gave Julie a reference on protecting yourself from that, but that's the best way to protect yourself. I worry a little bit about places where there are all these Canada geese running around parks. So you might want to go to places that are less attractive to migrating birds. And that too is going to go, again, it's timing related. There's a trough now. It's in the spring and fall when the birds are migrating, you're likely to see more problems from the birds.
I saw a lot of dead pigeons. In New York, there are a lot of pigeons everywhere, like rats. And I saw a lot of dead one on the street.
And is anybody testing them? Probably not.
No one cared.
Right. If we don't look, we won't have to deal with the problem.
Yep.
I think I remember in second or third grade, I was conditioned to stay away from even just like feathers. I think it was because of the swine flu. They told us like to stay away from animals, especially dead ones. So yeah, I think I got that clocked at a very early age. So that's definitely good advice. All right, moving on to the next question. What is the importance of vaccination, not just COVID, but also the early childhood vaccine series?
Get them while you can. Basically, you want to prevent infection. It's much better to prevent whatever than to deal with the consequences of the infection, be it, just being ill or needing to be hospitalized or the expense of care. So I'm big into preventive medicine. And that's again why I said that people should encourage people they know to get the Gardasil vaccine and the hepatitis B vaccine before they're no longer allowed, or it won't be covered by insurance. And that, by the way, is something, I'm sorry, I'm free associating, and this was not on your list, but with RFK going after dismantling the vaccine the ACIP, the Vaccine Advisory Committee. He fired all of it, 17 experts, and because they were biased, and he replaced them with 7 anti-vaxxers with really no experience or background, no expertise in those other than their anti-vax stance. So he's also attacking and he hasn't replaced them yet, but he is attacking the U.S. Preventive Task Force. And the way things are now, if a vaccine is recommended by the task force, then insurance will pay for it. And if it's not, if they change that and they change these recommendations, then you're going to be on your own to pay for the vaccines. So that's something to be, what happens to ACIP and what happens to the Public Health Task Force are something that you all should be politically attuned to and lobby about as well, because otherwise you're going to have all these other infections coming back that are vaccine preventable and that are transmissible because nobody can afford the vaccines.
But it's really scary that vaccines might not be covered by insurance anymore.
And this is, some people consider this an end run against dismantling the Affordable Care Act, as they haven't been able to do that legislatively, so they're getting around it by getting rid of all of the funding.
I think in this wave, I also heard from a lot of patients that they're unable to get Paxlovid covered by insurance as well. Paxlovid is costs about $1,500 per 5-day course, and there are actually patients that have to pay for a course.
Some of that is I think because there's debate over how much it helps and who it helps. Unless you're really immunocompromised, a lot of people think maybe it doesn't make much difference other than in shortening the illness. I'm just saying, I would want Paxlovid if I got sick too, but there's some debate over that.
My cousin who just got COVID, she's got Medicare with Medigap. She's got good insurance, and they denied her Paxlovid. She's like 69, and the pharmacist overrid them because if you have Medigap and it's not advantage with the insurance companies in charge, she was able to get it. But even on Medicare, they denied it.
Do you know why?
No.
Yeah, and the person that told me about his patient unable to get Paxlovid coverage is an oncologist. So we're talking about a cancer patient.
I don't know.
I definitely think taking Paxlovid is really helpful. I just recently had COVID, and I have long COVID symptoms. And during the course of the 5 days, I have never felt better. I have to say, it really helped me with the long COVID pain. And I was not having the pain for a few days as I was recovering from this recent infection. So, I mean, from my point of view, I encourage people to try your best to get Paxlovid if you can.
Right. No, I don't disagree with you, Julie. I'm just saying there's some discussion about it. I guess mostly if you're not that sick or not that immunocompromised. But I agree, I would want it too. Karina, you're on.
All right. Yeah, thank you for sharing all of that. Definitely agree that getting Paxlovid should be one of the top priorities for people who are infected and are eligible. So yeah, I guess staying on the topic of vaccines, you've already kind of given us advice to try to get the hepatitis vaccine as soon as we can, and I guess just get vaccines in general as soon as we can. But do you have any further advice on how to stay maximally immunized for COVID and everything else, given the uncertainty of vaccine access?
Again, with COVID, I'm not waiting. I didn't wait for the newer vaccines to come out this fall. As soon as it hit 6 months from my last vaccine, we got vaccinated. I similarly didn't wait for Novavax to get approved if it ever is going to be approved. So I would say stay on top of your vaccines when you're due for a booster. If it's been 6 months or 4 months, if you're more significantly immunocompromised, get a COVID booster. That's pretty much all you can do now. But don't wait for the new ones to come out, because God knows how long it's going to be if they're delayed.
Are we actually going to be able to get a booster with our
Yeah, right.
present climate?
Well, if you're 65 or you're immunocompromised, you can get a booster.
Yeah, I mean a new booster. I mean, I
Yeah.
have the boosters.
You can, right now they're saying if you're immunocompromised, you can get a booster.
Yeah, that's the same booster that came out, I don't know, 9 months ago.
Right.
There is no new booster.
There is no new booster until this fall, which is why I'm not waiting until October, November, or whenever they finally release the new booster. You get the current one, which still is protective.
Oh, I see. I see what you're saying.
You get what's available because it's still protective.
Right.
So don't wait on maybe something better coming along in the future. That makes sense, Phil?
Yeah, thank you.
Okay, sure.
Awesome. Yeah, I guess moving on to the next question. There's, I think, a hypothesis that has probably been debunked called the hygiene hypothesis, specifically as it applies to children. It says that children need to get sick to train their immunity. Does that mean that kids are safe to get or should be like exposing themselves to COVID, flu, RSV, all that?
No. It's not true. One of the many bits of misinformation. So COVID still kills kids, not as many as adults, but even mild COVID can result in long COVID in kids. So I would not want my kid to get COVID. I would want to protect them from that and RSV and flu, which also kills a number of children. So you get your vaccines that you have them get those vaccines. On the other hand, I always thought that, and you may be appalled, but there's something to be said for training immunity by letting kids grub around in their environment and play with dogs and cats and pets and crawl around on grass. That I think does build immunity, and there's certainly recent data that in the Amish that those who worked in the farms have lower rates of asthma and allergies because of that exposure to whatever animals, mold, whatever is helpful to them. But you still want good hygiene. You may let your kid play in the grass, but then wash their hands before they eat or when they're done. But no, vaccinate your kids. Don't risk them unnecessarily. And we've already talked about the next one.
Well, it's a little more specific. So,
okay.
The specific situation, this patient was actually my grandma. So basically what happened was the hospital didn't know anything about ready masks. And so she went into her MRI with ready masks I told her wear. And then the MRI tech forced her to switch to one of the cloth ones because, I don't know, they thought her mask had metal in it or something. And then she was like, is this an N95? And they were like, we give this to all our patients. They didn't say yes or no. It was not. So how do patients kind of deal with those situations and defend their rights to use a mask that they literally already have on?
You can't. Again, I'm sorry, Karina. You can't. You try to arrange things ahead of time with the hospital, the tech, the radiology department. If you know your grandmother needs an MRI, then you call them and you say, or you take them data about the ready mask, that this is safe. That's your best chance of getting a successful outcome, is educating them ahead of time. Because if you just show up, hell, the hospital around the corner here, I was wearing an N95 and I went to the hospital emergency room and they handed me a surgical mask. They said, this is what you have to wear. Put it on over my N95. Okay, I'm wearing it. But the best you can do for any appointment or anticipated visit is try to educate ahead of time.
Yeah, for sure. That's exactly what I asked my mom to do after, she would need more MRIs in the future. So I told her to just send a letter to the hospital system and be like, here's the NIOSH certification. And also, as somebody in the chat said, every time I tell them to also bring the packaging and the NIOSH certification in case they question that. So yeah. definitely letting people know ahead of time is probably the best bet.
I hope you all can save the chat for me because I haven't been seeing it, and I'd be curious what else came up.
I've been saving the chat as
Thank
it
you.
goes, so I will
Maria. I
compile it.
appreciate
Really,
that.
it's really frustrated with the infection control standard of hospital, like with clinical setting, and like also the CDC now, we don't have HICPAC and infection control standard being reviewed. I recently, went to visit my mom in the hospital, and I remember the security saying to me that I cannot wear my N95, and also gave me the surgical mask. And the security like threatened me that I would not be able to see my mom if I refuse to, follow the instruction. And that's how serious this is. That the infection control standard is really what is messing things up.
Right. And the lack of education.
Yeah, but they really follow order. It's really printed on,
Yes.
like he actually hand out like what exactly he's given order.
Right.
So even if they're educated, they still have to follow the hospital's infection control standard that was given them to these security people.
Right.
Yeah,
I'm
Tragic.
sorry that happened.
that's really sucks. Okay, moving on to the next question. So there's been been floated kind of Medicaid cuts and tariffs on pharmaceuticals. How do these cuts and tariffs affect prevention against COVID, the flu, and other infectious diseases? And specifically for Medicaid cuts, there's also a new, I think, work requirement in the cut. How does that have an effect on prevention?
I'm counting on you to ask me something with a cheery answer next.
Oh, sorry.
Again, making people work when they're ill is not a good solution for anything. And God knows I had to do that in my medical training. You could not call off sick for anything. Was that good for patient care? No. Was it good for me? No, but they didn't care. But for patient care, I mean, it's horrifying that you're forced to work when you're highly infectious because they will not let you off, and that's true with the Medicaid work requirements, and people with disabilities who are going to have to work if they are able to. That's not going to improve their health in any way. The tariffs on pharmaceuticals, everything is going to become more expensive, less available to people. Probably, right. So fewer people will be able to avail themselves of those things. And that's what I was saying. If you have to pay for vaccines and you're on a limited budget, who's going to do it, right?
It really sucks. Okay. And one more question. I believe this one is from the audience. When someone continues to test positive on rapid tests for 15, 20, 25 days on end, are they still contagious all that time, even past like the 2-week window?
I would have to review that, but I think yes. And I did learn that if you're positive on the NAT test, like Plus Life, then you are not infectious if you're negative on a rat test, because the rapid tests are, as Dr. Hoerger said, look more at infectivity. They're insensitive enough. So if they're positive, then you're likely infectious. But I can't swear to that. That's my last understanding of it.
Yeah, I think that would track, especially since rapid tests only catch like high loads of virus. So if you're
Right.
positive on that, you're probably shedding
Right.
on. All right, Julie, Maria, did we have any other questions we wanted to ask, or should we wrap up?
I'm looking through the chat.
I'm looking through the chat.
Yeah, there's one. Did we answer, is the current vaccine protective against new variants? Did we get to that?
No, we didn't. Dr. Stone, would you like to?
I can't give you numbers. I think they're generally pretty protective. I mean, there's been some, they're behind, and it takes a year to develop the vaccine, so they're behind what the latest variant is. But because the lineage is the same, you're targeting the parent or grandparent, it's still protective.
Let's see. Okay, thank you. Thank you for answering that. Let's see.
I think maybe if Dr. Stone, you can stick around and just check the
Sure.
chat like later during
Happy
break
to.
and just
I'm happy to.
answer some of the questions so we can have a dinner break for people before our next segment, which is Dr. Robi Tamargo.
Yeah, for sure. Okay,
Well,
yeah.
thank you again for having me.
Thank
I
you so
appreciate
much,
that.
Dr. Stone. Thank you
Yeah.
so much for being here. We love you.
Yeah.
Thank you, Julie, and
Yeah,
for
just
your
to
great work. You guys do great work. Rumor has it that Novavax will be available this fall, but I haven't seen any updates as to when. But that would be the alternative. And again, even if you don't have a problem with mRNA per se, Novavax has fewer side effects.
I guess, yeah, there's one more question about somebody with a preteen cousin who I think doesn't mask because of bullies. Is there any advice you could give to this person?
I wish. I don't know, maybe somebody who, Maria, did you put something in the chat about, okay, right.
What was the question?
Okay, lone masker, who's being bullied.
Oh, I did put in the chat some resources for kids, like World
Okay.
WHN Kids Zone magazine. I could repost my comment. And
Okay.
yeah, I don't want to like self-promote. I wrote a book on this for my kids, but I do have a free link to it that I'm also like putting out there. Yeah, so I put my comment back, but there's also I really like WHN Kids Zone magazine as well, just for boosting confidence of kids who are
Great. And that's something I'm totally unfamiliar with, so I'll have to look at that. Thank you. There's
Awesome.
just too much to keep up with.
Yeah, there's a lot of resources out there. Thank you, Maria, for sharing. So yeah, now that we are officially out of time, we'll close this out. So now we'll have about an hour-long break. So we'll be back at 6:15 p.m. Eastern time. And at that point, we'll be back with Dr. Robi Tamargo to talk about neuro-long COVID. So please do join us at 6:15 Eastern. And then just to roadmap the rest of this forum, right after that, we'll just have a 15-minute kind of community time closing session from 7:15 to 7:30. So thanks again, everyone, and see you in an hour.
Bye. See you later.
Bye-bye.
And there's a little plus button that says add image or video. And if you have that image saved, you can upload it to be your background image. Otherwise, you can, like I emailed it to you if you don't have it. Oh, you have it. There we go. We're all in the same background.
I did it. Thank you.
Yay.
You talked me through it.
Hello and welcome back again, everyone. For those of you just joining, my name is Karina and I'm a coordinator for MaskTogetherAmerica and also the MC of this Back to School Health Forum. Thank you all again for joining us today. We are so grateful to have our third speaker of the day with us, Dr. Robi Tamargo, who will be talking to us about the topic of neuro-long COVID. As a bit of background, Dr. Robi Tamargo is a clinical psychologist in Florida. She's currently a PTSD/substance use disorder specialist at the VA, in addition to her virtual private practice. She's been practicing for 30 years, starting her career by serving in the Navy on active duty and in the reserves for a total of 17 years. She has served as a consultant to the Naval Hospital Jacksonville since 2014. Dr. Tamargo has become a specialist in treating post-acute sequelae of SARS-CoV-2, PASE, specifically neuro-long COVID, which she contracted COVID during the first wave from an undiagnosed pediatrician, resulting in severe multi-organ system illness. So to seek care and support research of long COVID, Dr. Tamargo went to Mount Sinai's Center for Post-COVID Care in Manhattan, New York, where she participated in multiple collaborative studies by Dr. Akeko Iwasaki, the Sterling Professor of Immunobiology and Professor of Dermatology and of Molecular, Cellular, and Event developmental biology and of epidemiology of Yale School of Medicine, and also Dr. David Putrino, the director of rehab innovation at the Mount Sinai Health System. Additionally, while at Mount Sinai, Dr. Tamargo participated in studies targeting multi-organ systems, including cardiovascular, central nervous, digestive, muscular, respiratory, skeletal, and urinary, undergoing a multitude of diagnostic tests. Simultaneously, she participated in research, diagnosis, and treatment with Dr. Bruce Patterson at the Chronic COVID Treatment Center, which you can access at covidlonghaulers.com, which she found to be the most effective treatment she has received. She credits Dr. Patterson for saving her life with his experimental off-label use of FDA-approved drugs. Most recently, she participated in a 10-week trial with neurologist Dr. Sayed Assad in Florida using red light therapy, hyperbaric oxygen therapy, and hydrogen inhalation treatment. She praises these therapies as improving her health to about 85% of her pre-COVID health, which was excellent. And avid long COVID public health advocate, she's spoken on a multitude of television, radio, and internet news outlets, including NPR, WHN, Baltimore Sun, and Lehigh Valley News with Rob Vaughn. She's spoken with Florida's state and federal legislators advocating for healthcare for long COVID sufferers. And lastly, she's been a strong and dedicated advocate for the layered approach in preventing long COVID. And so we're extremely fortunate to have her as our long neuro COVID advisor. So moving into the discussion itself, for those of you just joining, how this works is that organizers have a list of prepared questions that we'll ask Dr. Tamargo first. And after that, with the remaining time left before our scheduled end time of 7:15 p.m. Eastern, so in an hour, we'll take questions from the audience. For audience members, if you'd like to ask a question, please write it in the Zoom chat at any time, and then we'll go through and ask them in order until time is up after we've gotten through our prepared questions. So getting into the questions, our first question is, what are the symptoms of neuro-long COVID?
Well, thank you very much for inviting me to speak on this topic. Those who know me know that I'm very passionate about this, firstly as a psychologist, and then secondly as a long COVID patient who had basically every symptom that I'm going to talk about today. I want to also say that I'm speaking this evening as a private citizen, a public health advocate, a founding advisor of Mask Together America, and a long COVID patient. I am providing general information and knowledge. I am not giving medical advice, diagnosis, or treatment recommendations. I do not represent my employer or any federal government agency. So to start with your question, firstly, let's remind everyone that long COVID is, the formal name is post-acute sequelae of SARS-CoV-2. So COVID-19 is the illness that causes PASC. And long COVID affects people in lots of different ways, and studies have reported up to 200 different symptoms associated with long COVID. And individuals with long COVID have lots of clusters of symptoms. And I had almost every organ system involved personally. So recent studies have suggested that about 25% of people continue to have cognitive symptoms beyond 3 months after recovery from the acute phase of COVID-19. And this is a very heterogeneous group, but most folks with long COVID suffer very similar symptoms that are neurologic, including dysautonomia, particular orthostatic intolerance, something that's called brain fog, which I will use that phrase simply because it is well known colloquially, but I am not a fan because I think that it diminishes the reality of neuro-COVID, and it trivializes the severity of this disease. So I will use it simply because it's a well-known symptom. Okay, so think of brain fog as cognitive dysfunction, okay? And it includes fatigue, fatigue and headaches and sleep disturbances and sensory disturbances. And that has become known as neuro-COVID. So neurological symptoms are among the most common array of symptoms that are associated with PASC. The effects on the nervous system have been really, really profound, and they're extremely broad. The virus causes severe inflammation around the brain blood vessels, which could lead to a myriad of neurological complications. There are long-term problems in cognitive and emotional functioning. Many experience changes in their general cognitive abilities, which they refer to as brain fog. And we'll talk a little bit more about what I mean by cognitive abilities in a moment. The changes include a sense of slower and much more effortful thinking, trouble concentrating, problems with your memory, slowed processing speed, and inattention. And the range of cognitive symptoms, like I said, it's very broad, with people, however, commonly experiencing chronic fatigue. And the numbers range from 28% to 87% of people with long COVID experiencing chronic fatigue. Some studies will say 60%, but that's the range in the studies. So it's a very wide range. But people who have COVID, acute COVID, report experiencing chronic fatigue as well. Also, impaired short-term memory occurs about 18 to 21%, poor concentration 16%, and these symptoms can occur alone or in combination with each other. So here are some other common things to know about neuro-COVID. So when we're acutely ill, lots of people lose their loss of smell and taste. That's a neurological impact, and that may persist. About 35% of people, when they are infected, have that. They say they lose their sense of smell or taste. People experience dizziness or lightheadedness, seizures, and encephalopathy, which is a fancy word for brain inflammation, but it alters your mental status. Headaches are extremely common, sleep disturbances, insomnia or hypersomnia, sleeping a lot, difficulty concentrating to go along with the memory problems, and of course to go along with the lingering altered smell and taste, I experienced something called phantasmia, and that is phantom smells. So in the very early days, I smelled, like I think my second day of illness, I smelled fire. And it was summer, so there was no fire burning in my fireplace, but my house smelled like fire, and I thought we were on fire. And that persisted for 1.5 years. It wasn't fun. So some other symptoms are autonomic symptoms like paresthesia, which is numbness, and other sensory symptoms, lightheadedness when you get up and try to walk, fainting, hyperhidrosis, extreme sweating, sweating the bed, sweating anything. You're just very wet. It's called hyperhidrosis. Inability to tolerate any exertion, tachycardia, chest pains, palpitations, all kinds of cardiac issues, blood pressure increases or decreases, and then mood changes, anxiety, depression, post-traumatic stress disorder, hallucinations, and delusions. So there are many acute neuro-COVID related neurologic complications like that would happen when people are in the intensive care unit. They will get a post-intensive care unit syndrome. And there are also rare autoimmune diseases that might be triggered by SARS-CoV-2, including things like a demyelination disorder or Guillain-Barré syndrome. I got both of those things 2.5 years in to my journey with long COVID. According to lots of studies, 36% of people have objective cognitive deficits. Excuse me, that's one of mine, where my tongue won't keep up with my brain, after COVID. And that's, as I mentioned, attention and concentration, but also executive functioning, which is judgment, impulse control, planning, organization, and time management. Delayed recall is also very common, where language difficulties and visual spatial deficits are also happen, but less commonly. Many people will present to a neurologist with post-COVID cognitive concerns, but they don't have any detectable cognitive abnormalities on the typical neurological exam, or even sometimes in comprehensive neuropsychological assessment. So I hope I answered that question.
Yeah, for sure. That was an extremely thorough answer. Thank you so much. So given those symptoms, how are patients diagnosed with neuro-long COVID officially by doctors?
Well, firstly, you should see a long COVID aware neurologist. Not all neurologists, believe it or not, 5 years and 3 months into, well, 5 months now, because it started in March, or even sooner if we really go back to January, right? So 5 years, 9 months in the United States. There are neurologists that are just not keeping up with the literature, but there is magnificent literature out there if they want to read about it, that are well published, well peer-reviewed, and in fantastic journals, highly recognized journals that demonstrate this illness. So the neurologist will, of course, conduct a full neurological exam, and it may be negative. Don't give up. They may also, and you should ask for them to do additional testing, because just having a normal neurological exam where they tap your elbows and your knees and your heels and have you follow their finger in and out, that doesn't mean things are normal. They may conduct things like an MRI of your brain, a PET scan of your brain, nerve conduction studies, or an EMG to see if you're having neurological issues that aren't showing up on the simple neurologic test. Please don't be intimidated to ask your neurologist for a referral to someone like me, someone who will do neuropsychological testing that is beyond the scope of a neurologist. Again, that may be negative, but there is a lot of data that's showing that people are experiencing cognitive decline that can be measured on assessment measures that psychologists use. Neurologists can also extrapolate treatment options and offer guidance and off-label treatments, which we'll talk about a little bit later. So the diagnosis isn't easy, but it's much better than when I was sick, because no one knew what to do with me. And I was told, unfortunately, by a gastroenterologist that my 90 days of diarrhea was all in my head, and that I had irritable bowel syndrome, which I never had and I don't have. I had long COVID. So I finally was well enough to ask that that be stricken from he diagnosed me with IBS and generalized anxiety disorder, and he never told me. So I saw it in the medical record. And so I've had that corrected. And just to let everyone know, you can have your medical record corrected. You just have to request it.
Awesome. I didn't know you could have a record stricken and corrected. That's really useful information. I guess once you're diagnosed, or I guess even if you're not diagnosed, what are the top 10 treatments for long COVID? And you don't have to stick with exactly 10, just what are the top treatments for long COVID?
I don't think I have exactly 10. I just listed what I know of. And so firstly, there are no FDA approved drugs for long COVID of any kind. That is very true with neuro COVID. So all the treatments that I'm going to discuss are off-label uses of FDA approved medications. So the treatment of cognitive complaints are focused on management of the neurological symptoms, which we talked about: fatigue, sleep, autonomic dysfunction, mood disorders, and physical and cognitive aspects. So there's not a single individual therapy that has demonstrated benefit. And listen to me carefully here. In prospective, randomized, double-blind, controlled clinical trials that have been published, okay? Doesn't mean they don't exist. It's just there are things that are finding challenges. Providers, researchers are having difficulty getting things published. Nevertheless, therapeutic options can be extrapolated from the ME/CFS literature, and that's myalgic encephalomyelitis and chronic fatigue, and that neurologists have been treating that, as well as other neuroinflammatory conditions like multiple sclerosis. So there have been wonderful studies, and a really small one that was recently published, which was a case series. It had 12 people. So an N of 12 is a very, very tiny study. So we can't extrapolate a lot from it, but it was still interesting. 8 of the 12 individuals in the post-COVID-19 cognitive decline study responded to an alpha-2 adrenoceptor agonist, which is called guanfacine, paired with an acetylcysteine. And that is one of them, and I'll talk about it a little bit later. It's one of the most commonly recommended treatments for the cognitive aspects. There are ongoing clinical trials exploring the efficacy of different interventions, such as amantadine, transcranial direct current stimulation, tianeptrine, which is an atypical tricyclic alpha antidepressant that is not available in the United States. It's not approved here. Methylprednisolone, which helped me tremendously. I also am treated with amantadine, and various cognitive rehabilitation strategies are very useful for cognitive dysfunction, which I'll go into further detail in a later question. My neurologist currently treats me with the following medications: amantadine, Luvox, trazodone, gabapentin, and Xarelto. I was on many, many, many more. And as I got better, we've weaned them down. Most recently, I began red light therapy, hyperbaric oxygen therapy, and hydrogen inhalation therapy. And that is a part of a study that my neurologist is conducting. And it is really well done, great design. And but again, it's not double blind, right? Because I'm telling you, I know what I was doing. And so they have published, it's in the literature, but again, it's not a double blind study. So I hope that's helpful.
Yeah, for sure. Super helpful. Thank you. So you did already touch on this when asked about the symptoms, but I guess if you have anything to add, how does COVID harm your nervous system?
Well, this is a little bit more complex than the symptoms. So the way it affects the brain and nervous system is incredibly complex. And there are several different biological pathways because there are different parts of the brain involved. So a prominent mechanism is the body's inflammatory response, which is often referred to as a cytokine storm. Most of us would hear that on the news in the beginning. And what this is basically it's a release, an excessive release of our immune signal molecules that are called cytokines that lead the body into widespread inflammation. And of course, this includes the brain. So the pro-inflammatory cytokines are able to cross the blood-brain barrier, which is normally something that protects the brain. And it is not able to do that with COVID, resulting in neuroinflammation and neuronal damage. So the virus can also impact the brain through vascular tissues. COVID-19 causes blood vessel damage, increasing the risk of blood clots and impaired blood flow within the brain. These microclots can block the blood flow to neurons, leading to microbleeds or ischemic injury, which means that you can't get oxygen to your brain. SARS-CoV-2 spike proteins can blind the blood vessel cells that are called endothelial cells that line the brain's blood vessels, making the blood-brain barrier even more permeable, allowing the inflammatory agents to enter the brain. Hypoxia or oxygen deprivation is another significant contributor to neurological effects. Severe respiratory illness can reduce your oxygen levels in the blood, which can then deprive the brain cells of adequate oxygen. Prolonged lack of oxygen can cause brain damage and contribute to cognitive impairments. Localized brain hypoxia has been observed in some post-COVID-19 patients, even with normal systemic oxygen levels. I had very low oxygen levels for a very long time, but in the beginning, I couldn't even get a pulse oximeter at my house. I just knew I couldn't breathe. And it took quite a while before I finally got oxygen delivered to my home. So it was several months without enough oxygen. Another is direct viral invasion of the brain. We now know that SARS-CoV-2 can enter the central nervous system via the nose through the olfactory nerve, which transmits smell signals, explaining the common loss of smell symptom. Evidence of viral particles have been detected in olfactory regions of the brain, and the virus can infect nerve and glial cells in the brain, though this is not considered the primary mechanism for most neurological symptoms. Autoimmune responses also play a role in neurological complications. The immune system, which is fighting the virus, mistakenly attacks the body's own brain cells. And this can occur through mechanisms what are called molecular mimicry, where the viral components resemble self-proteins, leading to the production of an autoantibody that targets nervous system tissues. And those autoimmune reactions are implicated in a lot of neurological conditions that are observed after infection with this virus. I participated in many studies at Mount Sinai's Clinical and Translational Research Center at the ICANN School of Medicine using MRI and PET scans. They use a 7 Tesla MRI PET research device, and there are only 17 in the United States. So I had the benefit of having those studies so they could see the impact. And they actually scanned my entire body. And then because if they found any abnormalities, they communicated with my providers at the Mount Sinai Center for Post-COVID Care. So all of my different providers could see the different organ systems that were impacted and provide me the treatments that they had available at the time.
Well, thank you so much for sharing all of that. It's definitely a very complex effect on the nervous system. Next, kind of a related question, is that effect, those harms on the nervous system, are they manifested in kind of the same, or do they happen kind of the same way that COVID affects the other organ systems, like circulatory, endocrine, vascular, and so on?
Yes, that's the understanding at this time. So yes, this appears to be true. And I'm a perfect example of that. And the most promising data indicates that this is caused by viral persistence. And I'll talk about that later in another question.
For sure. That is literally the next question. Could you define viral RNA and antigen persistence for us and explain if it's possible to clear them out?
Dr. Akiko Awasaki is the expert in the United States on this particular topic. So I'm borrowing data that she has shared here on our platform. And she's spoken extensively about her research at Yale University. And she was one of the first to really have published, not necessarily the first to identify it because others have identified it. But again, being as spectacular as she was able to publish her data, which identified viral persistence. Those of us that were sick, we've known it since the beginning. Those of us that are scientist practitioners that have been suffering with long COVID because it mimics so many other viruses that persist in the body. And so initially they thought it didn't persist, but now we know that it really does still persist. So basically what this means is that SARS-CoV-2 remains in our body and continues to cause changes even after we've recovered from the initial illness. So I encourage you to look at Dr. Akiko Awasaki's presentation on our MTA platform.
Awesome. Thank you for the great recommendation to refer to Dr. Saki's work. Next, we wanted to know how COVID triggers neuroinflammation. If you could talk about that.
Sure, I'll elaborate a little bit on that. So the way SARS-CoV-2 affects the brain and the nervous system, again, are quite complex. And there are multiple biological pathways. And the most prominent mechanism is the body's inflammatory response, called the cytokine storm. So this is that excessive release of immune signaling molecules, cytokines, which lead to widespread inflammation, including in our brain. And then the pro-inflammatory cytokines cross the blood-brain barrier, which is supposed to protect us from this wretched disease, but it does not, resulting in neuroinflammation and therefore neuronal damage.
I see. And related to that, how does COVID cause T-cell infiltration?
Well, the inflammatory cytokine storm is followed by our local immune system response, which may include, supposed to include, different specific virus-specific T cells. However, the type and role of the central nervous system infiltrating T cells in COVID are very complex and not fully understood. Nevertheless, some descriptive studies have found that COVID-associated T cells were present in various brain regions of patients who had fatal COVID-19 pneumonia. They found it within the olfactory bulb, which is how we smell, that part of our brain, the medulla, and the cerebellum, showing specific patterns of infection. So these T cells primarily consist of what are called CD8 asterisk T cells, and they are localized around blood vessels. And my testing that I had done at the long chronic COVID treatment center with Dr. Bruce Patterson showed off the charts CD8 T cells.
Wow. All right. Thank you. Thank you so much for that explanation. Another condition we were curious about is fibromyalgia, which is considered a nervous system disorder. Is it a common condition among your patients with neuro-long COVID? And how does the pathway work between COVID and then triggering fibromyalgia?
Personally, we could take a poll of everyone who's listening, but I haven't met anyone who hasn't experienced these symptoms. It is very common amongst people who have neuro-COVID. COVID absolutely triggers fibromyalgia. The expert in this is Dr. Rachel Bergmans. She's from the Department of Anesthesiology and the Chronic Pain and Fatigue Research Center at Michigan Medicine. She studies whether long COVID was distinct from other pain syndromes and whether chronic pain conditions increase the risk of features of long COVID. So the study that she led found that chronic pain increased the risk for long COVID. So if you had a pre-existing chronic pain issue, that you had an increased risk. Now, I did not have a chronic pain issue before, but I definitely developed these symptoms. So she has found a new type of pain that is called nociplastic pain. And this is due to heightened sensitization in the central nervous system. And she believes that this might help explain some of the findings. So this is a quote. She said, I quote, "With nociplastic pain, some people have what you might call a pain setting turned up in their central nervous system. There's evidence showing that infections, trauma, and stress can be a trigger for nociplastic pain features in and related symptoms. So Michigan Medicine developed a resource for patients with post-acute sequelae of SARS-CoV, and they provide advice for navigating this often misunderstood condition. Make sure that that's something that can be accessed.
I think I just dropped it in the chat if that's the resource you're referring to. But yeah, I totally relate. I think before I had COVID, I hadn't had an injury or any really pain since I was like 10, and I sprained my ankle. And just last year after getting infected, I remember I went to a rehearsal. There wasn't a single joint on my body that didn't have some kind of KT tape or brace or something, because it's just everything was hurting. So
absolutely. And so many of my patients tell me, every joint in my body hurts. Everything hurts. My muscles, all my muscles hurt. And I didn't have any of those things. I was in fantastic condition, no aches and pains to speak of. And boy, COVID had something to say about that.
yeah.
Same here. I just want to say, same here. I'm dying with pain every single day. COVID, long COVID pain, you don't want to have.
No,
Definitely wear your
absolutely
mask,
not.
protect yourself from getting infection. You do not want to have long COVID pain. It makes you unable to sleep, and the pain is the worst after you slept.
Oh, yes.
You wake up in the morning, you feel like you have gone through a battle. And I feel like
That's a great point, Julie.
they call it morning stillness. Get up in the morning, you're like, okay, I'm done fighting, and here's another day. I'm just gonna keep fighting then. That's long
Absolutely.
COVID pain. It's never over.
It's horrible.
It's horrible.
There's no treatment, no cure.
Yeah, if you guys follow us on Instagram, Julie actually took the time to draw a diagram of long COVID pain and put it in a post. So I've linked the post there. But yeah, very painful. Definitely wear your mask. Don't get those things.
Absolutely. It
yeah.
pain's horrible.
For sure. Next, a more uplifting topic, damage to the brain. Is that or any damage to another part of the nervous system reversible?
Well, based on my own experience, so it's anecdotal, my answer is yes. While it has taken 5 years and 3 months, and I'm not 100%, I am absolutely able to think much better than I could even 1 year ago. I'm sleeping better. I can read and write again. I can use a calculator. I can use a telephone. I can use a remote control. And I know these things sound silly, but I didn't even know how to work a remote control or turn on a television. I was completely impaired. I could do nothing that required thinking, basically. I couldn't write. I couldn't read. So basic things that we all take for granted, I was unable to do for quite a while. And I had it would come and go. It would get worse. We'll talk about that a little bit later. So sadly, this is the sad part to this question. There are some permanent injuries that can happen because of SARS-CoV-2. You can have a massive stroke that doesn't kill you, but leaves you permanently disabled. You can develop Guillain-Barré syndrome, which I developed, it'll be 3 years in December, and I was paralyzed for 6 months. So I can walk again. I can ride a recumbent bike. I can lift weights in physical therapy. I can cut my own food with actual real knife and not one of the adaptive knives, which I had to use for about 2 years. So the stroke issue is a really, really significant one. And the cognitive impairment can absolutely leave a significant wound. I am not 100% cognitively, but I am very functional. And compared to where I was when I had my cognitive assessment done in the study at Mount Sinai, I'm much better than where I was. Much better on all areas, on all the areas that are measured on the Wechsler Adult Intelligence Scale. And I struggled on some of the sections on that. So according to Harvard Medical School, universal. Even if people escape brain damage during the initial attack of COVID, they remain at a considerably higher risk of various brain conditions. I already mentioned strokes, but depression, anxiety, psychosis for several years, and we don't know how long yet. I did not have I had a TIA, a transient ischemic stroke, a mini stroke. I did not suffer with depression. When I got back from Mount Sinai, I developed anxiety in the car because my proprioception was off and all cars were coming right at me. I was a passenger. I couldn't drive for 2 years. Actually, it was more than 2 years. I didn't start driving 3.5 years, actually, because when you take into consideration the Guillain-Barré, this was a very long time before I was able to drive. Now I can drive without any trouble. So you can develop narcolepsy. You can develop a lot of different issues. So a large study was done at Harvard looking at MRI scans taken before and after people got COVID, and it demonstrated that it can actually shrink our brains somewhat. So sadly, the answer to this question is yes. So even though my own experience is that it's improving, it's just improving. I'm not fully recovered. So the potential that COVID can cause on the brain is one more reason to do everything we can to avoid getting this disease. Masks and social distancing, getting vaccines are really important, especially in crowded indoor places. Please mask up. Vaccines have greatly reduced the risk of getting COVID and becoming seriously ill from COVID, but they don't protect you from long COVID. Sadly, we know that. They do reduce the risk, but they don't prevent it. Okay, so there is damage to our precious brains. Sorry, that was not a great, went into the bad zone, right? When we have to answer a question like that, because it's sad.
Yeah, of course, it's the honesty we need. But yeah, as those bike helmets say, you only get one brain, so protect it.
Absolutely.
So, yeah. Our next question is another specific term that some of us have heard or had experience with, dysautonomia. Could you explain what that is and if that's a form of neuro-long COVID?
Yes. So when something like dysautonomia or POTS or any of these other illnesses that look like things that we are familiar with but don't act exactly like them, we call those COVID-like or neurodysautonomia. So yes, it's a form of neuro-long COVID. And lots of healthcare professionals and researchers discovered a link between COVID-19 and autonomic nervous system disorders, which is simply the big phrase called dysautonomia. And again, as a psychologist who was stricken early, I knew that I had dysautonomia and I knew my autonomic nervous system because that's my wheelhouse, the autonomic nervous system. That's where I work every day. And I knew I wasn't functioning properly. So researchers are learning much more about how these conditions are linked and how you can make some really crucial changes to improve the quality of your life. So our autonomic nervous system controls our heart rate, our blood pressure, our digestion, and temperature regulation. All of those things sound very familiar to what we talked about in the very, very first question. The sympathetic branch of the autonomic nervous system is our fight or flight response. Everybody's heard about that. And it gets active when you're under stress, any kind of stress, including medical distress. If we need to run because there's some other danger happening out in the world, it turns on. But our autonomic nervous system responds to internal or external stressors. And SARS-CoV-2 enters our body and becomes an internal distress activation of this system. The parasympathetic branch is our rest and digest system. And as you heard with my 90 days of diarrhea, it went on, but by when I saw him, it was 90 days. That wasn't working very well, right? So this system is supposed to lower our heart rate. Didn't lower mine. I was in the 200s, and it certainly messed with my digestive tract. So typically, these two branches are supposed to work in a balance and fluctuating depending on what it is we're doing. But if one stops working correctly, you're going to experience dysautonomia. Okay. So symptoms of dysautonomia: inappropriate tachycardia, sinus tachycardia. So your heartbeat is beating too fast for no reason at all. You might get dizzy and short of breath. Something that's called orthostatic hypotension. When I would stand up, my blood pressure would drop down. So then I wanted to drop down. And when I was at Mount Sinai in physical therapy, they had me simply pushing a ball up the wall. And the act of putting my hands above my head caused my blood pressure to drop, and I dropped, and off in an ambulance I went across the street to the hospital. And because it just comes on very quickly, and if from lying down, it can happen, even just getting up from a chair. So you feel kind of like you're dizzy, you want to hold on to something, you might feel confused. I was very confused when the first time they put me on an upright bicycle. It happened again. And so I was in the study, and Dr. Petrino has done tons of wonderful studies, and I was certainly a guinea pig, and that they learned very quickly that you can't put us on an upright bike. And then from then on, a recumbent bike it is for me. And so you can have syncope, fainting, or your vision can become blurred. Now, my vision became blurred immediately when I got sick, and it has never not been blurred since. I still have blurred vision. POTS, postural orthostatic tachycardia syndrome. You experience that fast heart rate, chest pain, dizziness, shortness of breath. When you can be standing up, you can be lying down. It doesn't matter. It causes the, quote, brain fog, headaches, and fatigue. These all sound familiar, right? And you can have what's called a vasovagal syncope, where you have that sudden drop in blood pressure that I mentioned before. And that's the fancy name for fainting. Okay. So there have been lots of studies that show the link between COVID and dysautonomia. And the estimates vary pretty largely, but we know that it's connected. So COVID-19 absolutely causes dysautonomia. It's not exactly clear how, but there are theories. Antibodies may impair the normal functioning of the autonomic nervous system. The chronic inflammation in the brain and low oxygen levels can trigger the sympathetic nervous system. COVID might awaken other viruses like Epstein-Barr viruses, all of the herpes virus, and there are many, many of those. You might have the overreaction from the nervous system that attacks the autonomic nervous system. It can enter the brainstem and damage areas that regulate your breathing and your heart functions. And of course, the autoantibodies that impair the normal functioning. Chronic inflammation and low oxygen can trigger the sympathetic nervous system. COVID awakens. Oh, I already said this. Sorry. This happens when you have long COVID. I said I wrote the same things again. So I apologize. And yep, I repeated myself. So that's the end of my question. I apologize for being repetitive.
Oh, no worries.
This is what neuro-COVID looks like in real life.
Yeah, thank you so much for that thorough answer. So you already kind of touched on this in this immediate previous answer, but is there anything you'd like to add about how COVID triggers POTS, how you can tell if someone has POTS, and how POTS might be able to be treated?
Yes, thank you. Well, certainly the way you get that abnormal heart rate, you might feel angry, anxious, irritable, chronic pain, difficulty breathing, heart palpitations, low energy level, nausea, vomiting, sleep disturbance, sweating, shivering, or visual problems. Those are signs that you might have long COVID POTS, okay? So one of the things to use for dysautonomia are compression garments, diet changes, There's medications to manage your blood pressure and heart rate, physical therapy I mentioned, and then reclined aerobic exercise, swimming, rowing, recumbent biking, relaxation techniques, diaphragmatic breathing, progressive muscle relaxation, guided imagery, meditation, chair yoga. Raise the head of your bed was one of the things. I have a wedge that I still sleep on to this day. If I don't, I won't be breathing very well. So COVID triggers POTS in a very similar way, right? You see that. So we have COVID POTS, like we had COVID dysautonomia. So think of it in that way. Colloquial brain fog, the heart rate, really fast heart rate, and the severe chronic fatigue. Okay. So lightheadedness, brain fog, memory problems, headaches, shakiness, spiking pulses when you're not doing anything. I mentioned all those, I think, already. Some treatments to increase blood volume that I experienced. There's one that's called volume expansion therapy, which is a combination of medications, and it's a medication and non-medication based treatment that Johns Hopkins University uses. They have a great program there, and they use off-label medications, and I pretty much had lots of these. Propranolol or any other beta blocker was prescribed to me. I have a Bradine. I'm not going to try to say all these properly. So pyridostigmine, you can say that physician there. Fludrocortisone, droxidopa, midrogine, which I can say because I've had that. Clonidine, methyldopa, guanfacine, stellate ganglion blocks, and transcutaneous vagal stimulation. And the physician there can pronounce all of those for me properly. Hydration is key. You must hydrate. If you get COVID, you must hydrate. You will not feel hungry or thirsty, but you have to hydrate. Okay. And dietary modifications. I was in a huge study at Mount Sinai. They took away all my good, healthy foods. I could eat no raw vegetables or fruits. They were very dangerous to me. They caused way huge inflammatory response for me. It made me much sicker. So it's all over the internet. There are wonderful things out there for how to eat like someone who has POTS. And then there is specific physical therapy like what Dr. David Petrino offers at Mount Sinai.
Thank you so much again for that thorough answer. Our next symptom that we want to talk about is brain fog. So could you explain what that is and if there's any ways that patients can get better or get treated?
So I just want to say again that this is a trivializing, dismissive phrase that is colloquial. It means cognitive dysfunction or cognitive impairment. Brain fog is neuro-COVID, okay? So please be aware of that and do not allow anyone to trivialize it and say, oh, I just have brain fog. There's no just brain fog. If you have brain fog, you have neuro-COVID. So what do we do about that? So there are no FDA-approved treatments. They're off-label uses. I am living, breathing example of someone who has been experimented on widely and deeply on all kinds of off-label medications. I was game. Yes, I will try anything that is FDA approved for something. If the provider thinks that it might help based on research, and they would share their data with me. And I said, yes, I will be a guinea pig. So I participated in studies that allowed me to know what the medications were because I needed to know because of how ill I was and all the medications I was on. My primary care provider who talked to me every single week for 4 years to care for me. He worked with all of my providers. He is a magnificent person. His name is Dr. Anthony Nioso, and he has his own practice here in Jacksonville, Florida, and he's amazing. So check him out. He has a concierge business now, and he is the best primary care physician aside from my best girlfriend, Dr. Anna Raffanon, because I have to, throw a pitch in for her, but she's not my doctor. So he's my best primary care provider that I've ever had. I also have a primary care provider at Mayo Clinic. His name is Dr. Jackson, Dr. Kendall Jackson. He is amazing. And, but Mayo Clinic was not allowed to support me in doing off-label experiments because they don't do that. So you have to be in one of their studies to get any of the medications. There were no studies in the early days, so I had to go find my own. Okay. So I mentioned the guanfacine and acetylcysteine, and another treatment for my cognitive impairment. At Mount Sinai, I was in a study, and this is very funny because I cannot remember the name of the program that they used because my brain was so bad. My brain would shut down. It typically, in the very first assessment that came up, and it would wake me up when I failed with a nice sound. And I'd be awake, and then I would start the next one, and then I would fall asleep. So I failed week in, week out. So they got some really wonderful data on how a cognitively impaired person on SARS-CoV-2 was performing. And after my brain got better after the treatments that I did, and then I got Guillain-Barré, and then my brain didn't work again. And I did cognitive rehabilitation here in Florida at Brooks Rehab, and I did weekly for 6 months. I went 3 times a week for 6 months. And I did 4 different interventions for 3 days a week. So they were 4 hours a day, 3 days a week for 6 months. And, but they helped. So there are many tools you can use for cognitive rehabilitation. Brain HQ is one. It's an online brain training program. I love it. And Luminosity. I love it. Both are really good tools, and I found them both very helpful. Okay. So I'll have to check in to find out what it was. I can't remember the name, and I was trying to put my presentation together. So I just have to acknowledge. And then the third thing is cognitive pacing. I could not have been on this platform since 3 o'clock, even a year ago. I would not have been able to prepare my answers and then talk about them in the same day. That would not have been possible for me. But now I have that ability.
Thank you so much for sharing your experience. And we'll definitely remember not to trivialize or minimize cognitive dysfunction for sure. Another cluster of symptoms we were curious about was dementia, Parkinson's, and Alzheimer's disease, especially in young people. How does COVID exacerbate or trigger those diseases in the young population?
So yes, the research does show that even mild COVID can lead to an equivalent of 7 years of brain aging, and that's very serious. Think of it basically as a traumatic brain injury, and when your brain is assaulted by COVID, it causes the inflammation, which is swelling. It makes it very hard for your brain to carry out what it's supposed to do. And some new studies just this past year, published in the New England Journal of Medicine, suggests that there is an indelible mark on the brain. We talked about this a little bit earlier, but their study is focusing on 18 to 44-year-olds. And so, I was in my 50s when I got stricken with COVID, but 18 and 44-year-olds are showing cognitive impairment. They have increased memory problems. There's shrinkage in brain volume and alteration in brain structures. There's prolonged inflammation. that that absolutely is commensurate with the 7 years of brain aging. In severe cases, the deficit can be equivalent to 20 years of brain aging. This is shown in autopsies where COVID is still present in brain tissues. Isn't that unbelievable? And the inflammation can make it really hard for the brain cells to regenerate, even though we do have neuroplasticity. So do you want me to go on and talk about the Parkinson's disease and Alzheimer's?
Sure, briefly, if you can. Yeah.
Okay. So studies have shown increased risk of developing new onset dementia in people older than 60. People with Parkinson's are experiencing worsening of their symptoms in the same mechanisms highlighted above in the beginning neuro-COVID discussion. This is best understood as another behavioral manifestation of neuro-COVID. Is it preventable? Well, it's only preventable by not getting COVID-19. We have to make sure we don't get it. So to prevent it, we need the Swiss cheese layered approach. And wear an N95 when you're out in public. Use a HEPA filter in your office. Wash your hands. Don't eat in public unless you're in an outside seating area. So based on, and I'm sorry, I have 2 other questions. You want me to just spit them out quickly? They're quick.
If you can, yeah. But I think the thing we wanted to touch on is like the last thing was kind of the effect of reinfections on long COVID. If you could.
Oh, yeah, I forgot to mention that. Yes.
That can be our last.
Reinfections. Okay. Let's see. I probably wrote that down somewhere, but here's what I'm going to say. Based on my personal experience, reinfection is absolutely harmful. My immune system was profoundly compromised. I have developed an inability to make white blood cells. And I had immunoglobulin, IV immunoglobulin treatment for 2.5 years every week. And those are 10 hours of my day of all those years that I'll never get back. But it has helped me recover tremendously. It's very expensive. Not everybody can get IVIG, but it really worsened. Every infection I got worsened my symptoms. Even if I had gotten better, it was as if I went all the way back to the beginning. I developed new neurological symptoms that I didn't have in the first 2.5 years when I got Guillain-Barré. And I had demyelination. I lost the use of my left leg, and I had paresthesia in both legs and both arms. But my treatment has reinnervated me. And I can now, if I get a neurological exam, I don't respond normally, but I do respond. And I didn't respond for a long time. My last illness was in April of 2023. That's the last time I got COVID. Got it from my mom when she came home from the hospital because they sent her home. And she then got me sick. And sadly, she contracted Guillain-Barré, and both of us had pneumonia. And my mother died after 10 days from Guillain-Barré. And in me, what happened is that in addition to the pneumonia, I had continuing spinal deterioration, and I was unable to walk again for quite a long time. I was in severe pain and had to go get very invasive treatments. And now I'm doing much, much better. I'm wearing a back brace, use a cane, a walker, a cane, all of those things all over again.
Thank you so much for sharing that. I'm so sorry for your loss. Even more underscoring the importance of prevention, especially in healthcare settings. You shouldn't come out of the hospital with more problems than when you went in.
Right.
That's just my opinion. So yeah, we are a bit over time, so I think we're going to go ahead and stop there. Thank you so much again, Dr. Tamargo, for taking the time today to talk to us about long COVID in the brain.
Absolutely.
And thank you to our audience for joining. So this officially concludes our speaker series for the forum. And as just a final wrap up, we'll take until about 7:30 Eastern for some community time closing. So for that, I'll hand it over to our founder, Julie, to share a bit about the work Mask Together America has done.
I just want to start by saying, Dr. Robi, so sorry for your loss. And I wish that I can give you a hug right now.
Julie, you were there for me every step of the way with my mom when she was dying. So I have to say that publicly. Julie supported me immensely during that time.
You're my sister. Okay, I have a lot of things to share with everyone. Thank you to our wonderful speakers, Dr. Tamargo, Dr. Stone, Dr. Hoerger. Big gratitude to Maria and Karina for hosting, and our organizers, Sydney Holsworth, Evan Sachs, Sharon Brown, Phil Nolans, and our audiences for being here. For more than 5 years, our team, supported by COVID-conscious people in the world, we promote prevention through our education platform. I am very, very grateful for your support. As a founder of this grassroots campaign, I was invited to join NIH Recovers community rep over a year ago. As a rep, I lead our group to lobby with public health officials to implement changes in policies regarding prevention. We propose a layered approach in prevention through communications. Representing the high-risk community, we met with the CDC in 2024, along with PAN-ANID and Long COVID Justice, 2 other amazing advocacy groups. As a result of our meeting with the CDC, at the end of 2024, the CDC actually promoted the layered approach that recommends measures such as improving air circulation and wearing masks instead of vaccinating and relaxing. And I also want to tell you about our poll. So 171 long COVID patients participated in our long COVID health justice poll. We launched that in March. This poll shares the barriers people with long COVID are facing in seeking diagnosis and care. They're heart-wrenching testimonies, like what Dr. Robi Tamargo just shared with us, motivates us to work hard to serve the community. Today, we are proud to be listed on NIH Recover's website as a long COVID support resource. Just days ago, NIH Recover's leadership unanimously agreed to include MaskTogetherAmerica's proposal of a survey question that outlined all the preventive measures in a layered approach, which will be part of NIH Recover's follow-up survey for their patient cohort. This will provide researchers data to study preventive strategies. To raise awareness about prevention of long COVID, we created a long COVID defense guide that promotes the layered approach. In addition, we updated the long COVID page on our website that includes long COVID's definition and resources for long COVID patients. And we also relaunched the Save Our Right to Mask campaign this year to encourage everyone in the United States to ask for legislation that protects our right to wear masks indoors and outdoors and prohibits mask restrictions or bans. Our campaign is co-sponsored by prominent advocacy groups, including COVID Action, GSO, PAN-ANID, Long COVID Justice, Senior Disability Action, Care Not COVID, Chicagoland, Long COVID Foundation, ME Action Network, and World Health Network. To date, more than 12,000 letters have been sent to elected officials. And I want to talk about our chapter, Mask Together Colorado, led by Professor Maria Gillespie, was initiated in 2024. This amazing team in Colorado works with state officials to lobby for policies on air quality guidance and the right to mask. We hope this collaboration will inspire more people to start local groups that expand our core mission, which is to normalize prevention everywhere. I am suffering from long COVID pain and other symptoms since contracting COVID in the winter of 2021. But despite my declining health, I will continue to interview maskers for a documentary project I started in 2020 to help people see the humanity behind a mask worn by worn by people for health protection. As we face threats to our public health systems, our coordinator, Karina, initiated this health justice toolkit, working with our editors, Kathleen Downs, Debbie Sokola, and myself, to provide letter templates for Americans to oppose cuts to public health funding, programs, and workforce. And together, we want to lobby for life-saving healthcare-related policies. With that said, I will pass the mic back to Karina, and she will talk about this amazing teamwork. Thank you, Karina, for your vision and leadership.
Thank you, Julie. As Julie mentioned, I've headed up the launch of our Health Justice Toolkit, which I've linked in the chat. It's a toolkit of letters that everyone can write to their elected officials about various health policy issues that are critical in these times. So the topics include fighting to preserve Medicaid, Social Security, public health research and monitoring, food and water safety, physical and mental health care for high-risk people, and preserving the staff that work at the agencies that make these public health programs happen. So for example, we want to preserve the Environmental Protection Agency and also the NIOSH, which if you guys wear N95s, it's the National Institute of Occupational Safety and Health, which is the agency responsible for actually certifying that your N95s and P100s that you're wearing actually have good filters and have good seals and they're not fake. We also have, as somebody mentioned in the chat, we are doing something to fight to preserve vaccine access. That is actually several letters. We have a federal letter, and then we have some state-specific letters because there were some kind of mRNA and like random vaccine bans floating around in different states. So we also have templates for that. So we definitely do address vaccine access. So for every topic, we have a basic letter template where you can just like sub in. We have like it just says city, you can just sub in wherever you live and that's your letter. And then we have a link to which officials you should contact. So some of them are state level things. Some of them you should contact only the House because it's like a House thing, or a Senate committee thing. Sometimes it's the governor's thing. Sometimes it's the Attorney General in power that can do something. So we have a link to who you should contact and then some ideas for talking points you can use to personalize your letter if that thing applies to you. For example, if you tell them you have a loved one who needs to travel 100 miles to the nearest Social Security office, that can make your letter so much more powerful. So we can kind of give you ideas like that to make your advocacy more effective. So you can access the toolkit at the link I dropped in the chat, which is bit.ly/fight4health justice, the number 4, and then the first letter of each word is capitalized. And so the more letters these officials receive, the more likely these programs will be saved. So please do write as many as you are eligible to write. And we know this can feel so hopeless in these times, but the fight isn't over unless we say it's over, unless we give up. So we encourage all of you to not give up and keep taking action. Another resource we want to share with you is, as Julie mentioned, our Long COVID Defense Guide. This guide talks about how to prevent long COVID and seek support if you do have it already. We go through a Swiss cheese approach of preventing infection in the first place, and then having early treatment and isolating yourself to prevent further breadth, so like spread or depth, like severity of your own infection, and also seeking medical and community support if you do have long COVID, and then of course preventing reinfection to keep your long COVID from getting worse. So the link for the guide is dropped in the chat. That's on MaskTogetherAmerica's website. We encourage you not only to use this guidance for yourself, but also use it as a resource to talk to people in your community, like maybe your schools, your families, or your workplaces. You never really know who will listen about prevention. Another resource we have is our Stop Mask Bans toolkit, which Julie mentioned, which is at bit.ly/stopmaskbans, and the S, M, and B are capitalized. So we invite you to use this letter campaign to ask for legislation to guarantee our right to mask protection and strike down any bans to mask wearing in any form. And so just to be crystal clear, this toolkit is completely separate from and unaffiliated with the website stopmaskbans.com, which we've had some community members raise it to us. That's not us. That's not our organization. So we're completely two different things. We have a bit.ly, they don't. But anyways, There are a growing number of proposals for mask bans of various forms cropping up since about 2 years ago in different states, cities, counties, and even across the world in places like, I think, Victoria, Australia. So each proposed ban has kind of location-specific complexities and location-specific ways that you can take action to stop the ban. So that toolkit is organized by location, and we encourage you to scroll through it and take all the actions that you can to save our right to protect ourselves with masks. And finally, we wanted to invite all of you to join the Mask Together America campaign. You can do this in various ways. The simplest way is to share our posts. Instagram has that ever so annoying repost button that you can accidentally press right below the comment button, which feel free to leave positive comments, engage with us. So we have platforms on Instagram, Facebook, Threads, X, and Blue Sky. If you are on any of those platforms, please do follow and support us there. And another way to contribute more personally, I guess, is to email us at MaskTogetherAmerica@gmail.com. Send us a portrait of you wearing a mask. Can be you just yourself or with a friend, with a partner, with a family member, anybody you have the consent to post, along with a short blurb about why you mask. And these are featured on our social media sites as a PSA to encourage people to mask. So you can scroll through our Instagram to see what these features look like and see if you want one for yourself. So that's all from us. Thank you so much again for attending this forum, and thank you again to Julie, Maria, Sydney, Evan, Phil, anybody else I forgot to name, and all the team members and speakers for making this happen. So yeah, we hope to see you engage with our campaign and attend future events.